en particular, no, O'Shea, Chichicello, or without curiosity.
Just a reminder to turn your readers down on your phones, please. Thank you.
Okay, we had some members that called in, want to be excused today. We have Sherry Wright Plank has called. Bill Marshall called in. Michael Lunderman, Wayne Fredericks, and Kathy Woodenknife won't be with us today, so we'll need a motion to excuse those people. Charlie? Question? Martha? Second by Martha. Question by Stan? All in favor?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Opposed?
0.
Not voting?
0.
Okay, Council, you have the agenda. We only have one item on there, the Tribal Health Alliance update. So we need to approve our agenda. Yes.
I have something, but after the presentation is over, I have something for under discussion if we still have a forum.
Okay. Need a motion to approve our agenda. Lisa's moving, second by Jordan. Question by Charlie. All in favor?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Opposed?
0.
Not voting?
0.
Okay, we'll get right into our agenda. Council, our chairman is not with us. He's at a meeting in Rapid City, so that's why I'm here doing the meeting, so. Lisa?
I had, so today is our regularly scheduled health board meeting. Dan Crew with Allied Health and our SOHS board is here. They did go out to the communities and educate some of the majority of the communities. I don't know how many they have gotten to for sure, but they can let us know. And they were gonna present to health board today, give us an update, let us know where they are, and then there was a council motion that they present to the council, so that's why we had a special council meeting for today, but we can go ahead and start with them, and thank you all for coming today and presenting to those of us that are here.
Okay, I guess our spokesperson is Chris Walker.
Correct.
Okay.
Thank you so much.
Thank you for coming.
It's a pleasure to be back among you. And Elliot and myself were here in October and started a presentation that was around the self-governance process. And during that time, there was the opportunity that we heard from various community members. And so I'm just giving a snapshot of how we took that meeting and what it was today. And so at that time, there was a request to slow some of our activities until communities. And we'll be rotating members over for you guys to hear from. So at that time, we provided technical support to Tribal Health Administration to conduct the various community meetings, and those began in October and went through December. And then there was one other that was on early January when you had the snowstorm, and Scott Miller on our team and myself, we traveled out here to host that meeting at the Antelope Community's request, and that's when you had a snowstorm. So we actually held it virtually the next morning and had probably about a 2-hour meeting and with the individuals that were on that call. And we assumed that they were from that community as well. And so through that process, there's been significant information that's been gathered around concerns of the healthcare delivery system that exists on Rosebud Reservation today. And so part of the charge that we had in December was to develop what is the plan moving forward with the health board and the assumption, or those activities. So The Health Board has been meeting actively since December, and so we have a draft document to share with you, which is entitled The Plan for Operating and Improving the Rosebud Hospital. So, Russ, if you want to start passing that document out to individuals, I would appreciate it. And I want to take a time to introduce a couple other folks that have traveled out here to participate in this presentation today. And again, we thank you for everybody's attention on this. So I will start. We actually have 3 of the board members present today. The chair of the board is Dr. Don Warren, and he'll be speaking quite a bit, addressing the position of the health board regarding its plan on making these improvements with some timelines. And then we have Dr. Plumage, and he's in the back sitting for some reason next to Dan, but that's okay. And and then we have Dr. Kellner, and Dr. Plumage is the vice chair of the board, and Dr. Kellner is the secretary of the board. And when they come up, we will have them, and that's what I want them to do, is come and give a little brief introduction of whom they are at that time. And then on our team, we have Russ Peterson and Scott Miller and myself. So we'll all be taking different times to be a part of this update, because there's several significant pieces of information, and one that we've heard clearly about is what is the plan and what could we see in the future? And also a part of the agenda, we'll discuss the replacement of the facility, and because it is outdated and there's several opportunities for that to be discussed, and then some next steps. So we're here to actually, answer any type of questions that you may have from reviewing it. So there's going to be, they have all the documents, correct, Russ? Okay, so there's about 4 different documents. Some are several pages, and some are just a 1-page. It's information at that point. So at this time, I would like Dr. Warren to come up and introduce himself. And I'm just an MC today for all intents and purposes as well.
How Pilami Ayalo, Mitaki Epi, Donald Warren Machiapi, Trijuta Bichasha Lakota Machiapi. Hello and thank you to all my relations here today. My name is Dr. Donald Warren. I've met many of you in other settings before, and just very pleased and honored to be a part of these important discussions as we move forward. I'm Oglala Lakota, originally from Kyle on the Pine Ridge Reservation, and I'm a family doctor, and I've worked in Indian Health Service and with tribal programs over the last 30 years. I finished medical school actually in 1995, so almost 30 years now. And I'm very honored to be a part of this effort, and was very pleased to be asked to serve on the board for the Chichangu Oyate Health System Board. And when I think about these opportunities as a doctor, someone who's actually provided medical care in IHS and in tribal programs, I'm very excited about opportunities and the future. To just give you a little bit of background in my own experience, when I finished residency in the 1990s, I went to work in Arizona, and I could see patients at Phoenix Indian Medical Center, which was IHS, and also the Gila River Indian Community, which was a 638 site. And just in my own experience, I didn't know anything about 638. I really didn't know a lot about health policy. But when I was at the IHS facility, the medications I could prescribe, for example, for diabetes, were the medications that were on the IHS formulary, a very limited list. And then I'd work at the tribal facility, and they had newer medications, better medications that I could use. And I said, why is this? I mean, in many cases, it's the same tribal community members, but if they're being seen at IHS, I have less options as a doctor than if they're seen in the tribal program. And I was asking, why is that? And that's when I first learned about 638. And under 638, there's just so much more flexibility. And what we see with tribally operated facilities, whether it's hospitals or clinics, we see better medications, we see the newer medications, we see a lot more flexibility. And the part of this that got me so interested in health policy, but also committed to self-determination, was in my own experience. I could provide higher quality of care in the tribal facility than I could in the IHS facility. And that's not the fault of IHS, it's just the system. And the better systems in Indian country are the ones that are operated by the tribes. So that's why I got interested in this, nearly 25, 30 years ago, is my own experience as a doctor and recognizing that with the flexibility of local control and local priorities for healthcare, we can do a better job of caring for our people. And that's just my own personal experience, and I'm really excited to see this move forward here in this community, my sister tribe, Shichangu Lakota. And just thinking about what you've already done here in this community. I do a lot of work in health education and medical education. And you probably know, but the Sintegleshka University is the first tribal university to be accredited, and that's right here. I mean, there's been a long history of innovation out of this community. I'm very proud of all of that work for our people. And I see all kinds of opportunities. We can talk about those more after we finish the introductions, but I just wanted to let you know where I'm coming from and why this is so important to me. And I really believe that our people deserve the best health care available. And IHS as a system has so many limitations. And as we learn more collectively about 638 and opportunities, I hope that you'll also see that really the long-term goal of this is to provide better care, make sure that our people live longer, healthier lives, and have access to the services and the medications that they really need. So that's my purpose for being here, and I'm deeply honored to be asked to be here, but also to be on the Shichangu Oyate Health System Board. So thank you. And then we'll talk more, but I wanted to let others introduce themselves. Maybe I'll call Dr. Kelleher to go ahead and come on up. And she has tremendous experience also with tribally operated facilities and is very humble. So I'll let you know she's a board certified family doctor, but also trained in traditional healing in the Athabascan traditions. But I'll hand it over to Dr. Kelleher.
And Dr. Warren's a very humble person as well. Just this morning, he was one of the keynotes working with a group that is developing an association around the Native American Graduate Medical Education Association. And so it's a privilege to have his interest in that area with his affiliation with Johns Hopkins. And another board member who was not able to be here with us today is Mr. Bill Snyder. And he was with Levitt Group, and they are one of the principals that are working to develop this whole association. And Mr. Snyder is the former state Medicaid director of South Dakota. So, and in tribal healthcare systems and IHS, Medicaid is a significant payer for the services that are rendered in those. So, Allison.
Masi Wopila. I'm Allison Kelleher, Manoid Lakasa Uzatle, Gutanats Lantani, Zagatsithni Tehutanats Landala Hedohutsan, Sudan Salet. I speak to you in Danakanaga. I'm Dana or Koyakan Athabascan. I follow my mother's clan line for as far back as I can remember, as we can remember. I was born and raised in Nome, Alaska, and as Dr. Warren mentioned, I'm a family doctor. I'm also board certified in integrative and holistic medicine, so I'm double boarded. And also I teach and research at Johns Hopkins University, but I have lots of different experience. I wanted to talk story a little bit today around my experience becoming a traditional healer in South Central Foundation up in Alaska. So in my journey, I come from a long line of traditional healers, and I knew from the time I was a young girl, maybe 4, when I started walking on backs, I knew that the gift of healing was what I had been gifted and wanted to pursue. And so that's why I became a physician. But working for the Indian Health Service, I couldn't train as a tribal doctor or a traditional healer. I worked at the IHS in Arizona in 2009 to 2011. I worked for Tohono O'odham Nation. And there I worked in clinic, ER, inpatient, and lots of different services. I work over 80 hours a week, and it was really busy with, as Dawn mentioned, not as many resources. I couldn't always use the newer medicines, and I felt sometimes like my hands were tied. We didn't always have the equipment that we needed to provide the care at the IHS. So when I later transitioned to working for our tribal health settings that were 638'd in Alaska, that's where I could work with our tribal doctors who were working side by side with us, and I also could train with them. So now I've become a tribal doctor myself, and I can help other health systems because we were able to 638 and create programs for our people, by our people. And so I really appreciate the opportunity to do my best to listen and to serve you, my relatives. So I want to thank you so much for this opportunity to serve as your secretary, and I really appreciate each and every one of you in this momentum as we're going forward. Hardly anything is 100% good. I have to acknowledge that duality in the universe, and so sometimes if things aren't perfect, they're still good, and moving forward is what I'm hoping for. Anamasi Kuyana, I'm so grateful for all of you. Thank you. Thanks, Chris.
Thank you. Another position she holds is she's on the board of directors of the American Indian Physicians Association out of Oklahoma City, and serves as their secretary as well, and is a part of an international Native American traditional healers group. And in a couple of years, the organization, the United States organization, is hosting the international meeting here in the States. So she's got some responsibilities around that as well. Okay, Dr. Plumage, if you could.
Good morning. I'm also humbled and honored to be here. I know some of you, and may know you through taking care of your relatives. I also graduated in 1995, and for the past 30 years I've been practicing medicine based out of Pierre, South Dakota. I've contracted with Eagle Butte, Fort Thompson, Lower Brule to provide care. I was medical director at the White River Nursing Home for a number of years until recently stepping back from that position. My story with 638 is fairly simple. My home reservation is in Fort Belknap in Montana, on Knee. My brother was born on the reservation, but since that time frame, there have been no other babies born to the reservation. The reservation is recently 638, but in that time frame between being IHS run and tribally run, we've lost our hospital. What we have is a clinic. All of our health care is predominantly referred out. We can't take care of our elders, our veterans, even relatives that need care. They're all shipped 60 miles away to the hospital in Havre. That requires motel stays, travel. So what I've seen in my experience with 638 programs is they bring back ownership of the hospital back to the tribe and to the people. They give them some flexibility to recruit, flexibility that the U.S. government does not have, and that your tribal leaders, your tribal health board, and the people you appoint, citizens will be able to help in decision-making as far as trying to recruit providers back, trying to train providers locally. The one example I would cite is your university. The nursing students do not work at the IHS hospital here, but I have extensive experience with them up in Pierre. They come up through the emergency room now. I see them in hospitals.
They used to go to White River to the nursing home?
They do.
Yeah.
And it would be nice to see them trained at home.
Oh, exactly.
Your goal is to recruit them and keep them
Yeah,
here.
that's right.
When they get experience in Pierre and they see we hire, that's the best way to put it. The goal would be to have them trained here, and as a tribal facility that would help, you might be able to keep more of your people here. I'm also honored. Thank you. If you guys have any questions afterwards, please feel free to call, text, anything. Thank you.
Okay, I'll have Russ Peterson come up and introduce himself and kind of share what he does in the background to support the Tribal Health Alliance's work with the health board.
Thank you. Once again, I come before you. I was here before with some of you. I work with Chris. My experience is I worked with the Indian Health Service for just under 40 years. I'm an engineer by trade. I spent the last 10 to 12 years running the Office of Tribal Support out of Albuquerque, so I I was on the federal side and I did all the Title I contracts, and then I became an agency area lead negotiator, and I negotiated compacts on the federal side. The one closest to you is I was the agency lead negotiator for the Winnebago compact. They sacrificed me and sent me up there. Made me do that one, which was a great experience. So what I bring to the table with Tribal Alliances, one is I know facilities, because I was an OEH, I'm an engineer, I deal with facilities, but I also have lots of experience sitting on the IHS side of the table during negotiations with tribes about taking over healthcare. So it's an honor to do that. I really like being on this side of the table now, using my experience from all those years with the Indian Health Service. So thank you, and I'll be presenting some of the stuff later as we talk about replacing the facility, and then in this part, I've kind of been running the finance side, so I can tell you how much money is at the hospital and all that kind of stuff. So we'll get to that. So thank you very much.
And I'll have Scott Miller come up and introduce himself.
Scott Miller, Nita Ikupi. My name's Scott Miller. I'm a absentee Shawnee. I'm a former tribal leader for my tribe back in 2005 to 2009. I worked in and around health and self-governance ever since that time. We were the fortunate recipient of what Chris alluded to as a facility replacement in the joint venture program that expanded our health clinic from a 9,000 square foot facility to a 72,000 square foot facility. We were in the same situation where we referred out a lot of services. So with this new facility, we were able to bring in those services with really specialty care such as cardiac and things like that. Surgeries were used for referrals. So also my tribe was one of the first 14 to go self-governance way back in the day in the early 90s. We were a demonstration project. We felt that IHS wasn't fulfilling their obligation as far as providing quality health care to our people. So we were one of the first 14 to be part of that demonstration project. We ran our clinic in Shawnee and then eventually built a new one, and which was our main clinic for several years until our replacement clinic. We've been through the trials and tribulations of negotiating, but back in those days it was a little bit different because we were actually negotiating line item by line item and what those line items were. So all that's been done before. So now today, the negotiation piece, when we get to it, will be actually what shares are you getting, because they're already formulated out. But being self-governance, it gave us that opportunity to start new programs, to serve our people, and our referral system, we practice, we know there's a priority system, but we're able to refer anyone out for almost anything medically necessary. So we don't necessarily practice that priority system that IHS has. So that's one of the advantages, and of course, you see advantages with your funding agreement with new monies coming in that are reoccurring or one-time monies that will help existing programs. So my tribe's been through the battle. We're still battling, so to speak, but we've benefited greatly from being a self-governance tribe. And lastly, I'll just leave you with this. Being a Title V tribe, your voice is even louder than it is now. Mm-hmm. You're able to be part of those negotiations when it comes to policy making with different committees that IHS is mandated to have when it comes to new programs or revising policy. So, once this takes place, then tribal leadership will have that opportunity to be on those boards and be able to share your concerns and help steer policy to better help your people. So with that, Ini, Yahweh, thank you.
And just, again, I'm Chris Walker, and my background is about nearly 30 years ago, came into tribal healthcare systems. I came from rehabilitation management, working with brain injury and stroke patients, orthopedic patients in the private sector. And lo and behold, what was the important thing is, what were our shareholders getting out of the deal called a return on their investment in buying the stock in a company? And I witnessed how even in corporate America, there's a leveraging of, we become technicians and we don't get to really do our work. And so I left that arena nearly 30 years ago, and I joined my tribe, the Cherokee Nation of Oklahoma, and served in a capacity as a health director there at a clinic, and then eventually became the executive director of the health system. And we were in a dynamic situation where we were in 14 counties, in northeastern Oklahoma. And at that time, under my leadership, we just operated the clinics and the behavioral health system. We didn't have the hospital, but we took part of the PRC money. And so there was always this issue of how could we partner better with the Indian Health Service that was there, because we had some resources. They couldn't receive any money. They couldn't go into partnership. And we were looking at, we're sending people out to get this, but we can't reinvest the money into the IHS system. So we joined partnership with the local general hospital in Tahlequah, Oklahoma, and started delivering other types of care systems with them. And that practice continues today, where we have ear, nose, and throat doctor, and we do nuclear medicine and these type of things. So that was kind of my experience. I thought IHS will be transparent and would love the tribe to come alongside them, but they had all these barriers that we can't participate. It's either us or it's you. It's not an in-between type of situation. And Russ and I are working with another tribe right now that's going down the same path that you're considering. And this is in another state. There's a hospital. IHS had a terrible time recruiting for emergency medicine and inpatient services. So what was their plan? We closed the inpatient. And that's what they did. And now this is a tribe that's looking at what now can we do to continue developing services, and who's the partner. So these are strategies that tribes find themselves into. And as we look to see at Rosebud and the impediments that the facility has, and we will say this, it's not generally, the impediment doesn't exist at the local level. It's a system issue within the Indian Health Service. It's how they have procurement. It's how they have their HR system. The decision makers aren't local. They may get to interview people, but all that onboarding and recruiting is happening somewhere else. And so often, this facility may get looked over, and that physician, that nurse is actually lining up at some other facility somewhere else. And so we want to change those type of processes. So I'm going to have, that's just a little bit about myself. So for almost 20 years, I've been the manager and owner of Tribal Health Alliance. And we work with existing tribal health care delivery systems on improving their third party, maintaining their accreditation, assisting them in various activities, looking at how they can use some of their resources to expand into other types of services on their reservation and communities to meet those needs, whether it's around long-term care. Here, years ago, you went down the path and you started a nursing home. And so you're kind of a leader in that area with that. So, but that's enough about myself. This is about the board's plan. So I want to invite Dr. Warren back up to visit. Now, did we want to do a little discussion around the replacement of facilities and those strategies? Okay, well, let's do that now, because I'll get another chair up here. So you should have a sheet.
Okay, that's fine.
Well, we can all be up here.
Yeah.
There's no chair.
So we've had this, in one of the presentations we gave earlier, we talked about it, but there's, okay, yeah, thank you. There's talked about replacing the existing hospital because it's undersized, and as you move forward, you know, you want to do a replacement project. So there's several ways to do it, but one area that we've kind of heard recently that the Indian Health Service is going to open up what they call the joint venture program. And there's a little 2-page article here about joint venture. Joint venture is a program that started in the 1992, early 90s. It's a program that Congress authorized where if a tribe finances and builds a new facility, the agency, IHS, will then fund the staffing package, which is an annual cost every year for the new staff. Because if you build a building, you have to have staff to provide service. So that's the trade-off is the tribe builds the building, the agency then funds the staffing, and then tribes compact or contract for that money to run it themselves. So as it says in the document, since '92, I think they've opened it like 4 or 5 times. And what they do is they open it up about every 5 years. They go through a process, they select 5 projects, they move those projects through the design phase, construction, and when they're ready to open, then the new funding comes for staffing. And we've heard that Director Sioux with the Indian Health Service is going to probably open it up again this summer. It's been, the last time was in '99, I believe. About 5 years ago they had it open. They selected projects, so now they have to do it again. So they do it in 5-year increments so that you don't get a project selected 10 years ago and it has to wait 10 years to get built. They do it as the need goes. It gives tribes time to plan. So this document pretty much talks about that process. It's an easy application to start with. You kind of just go through the process and get scored, make it through phase 1, and phase 2 is where you have to put your finance package together. You have to show IHS that you can finance the project, you can manage the project, get it constructed, and once they give you the go-ahead, the tribe signs a joint venture agreement with the agency, then they will staff it. The key document, though, is a single page that looks like this. The Indian Health Service has what's called a health system planning software, and that's what they use to do a lot of to get their numbers in their initial planning. I have access to that, and I ran some very preliminary numbers. Now remember, as you move through this, you have to involve a lot more people to do real design and real different things, but this document will tell you that user population, the top number, Rosebud's current user population for 2020, I think that number is 2022's number, is 12,494 users. Once again, a user is someone that has touched the system at least once in the last 3 years. When you plan a new facility, you plan out 10 years from now. So in the program, they have it built that based on this formula, that they predict that population would grow to almost 16,000 in 10 years. So right now, the facility is just over 100,000 square feet. But if you were to build a new facility right now for the 2034 population, you need a facility somewhere around the size of 230 square feet. And that would bring in other services like labor and delivery again, and surgery and all those types there would be space for all those programs. So what I did here is I ran that number, and then if at $750 a square foot, that comes to like 172 million. At $1,000, who knows in the next 2 or 3 years when you would build this what the cost of construction is going to be, but it gives you a range that you're in the 170 to $230 million range for that size of facility. But with that size facility, you should have a staff of 574 people, is what the program tells us. IHS agrees to fund that at 85%. That's part of that is they expect 15% to be funded through third-party revenues. So 85% of that would be 488 staff people. They currently have 298 positions on their books. Now, about 80 of them are vacant, but they have 298 positions. So if you subtract, and these numbers will fluctuate, but if you subtracted that, you would end up with a staffing package of around 190, 200 new positions, which at $125,000 a position is $24 million. at $150,000 position. They average these, so you have everything from kitchen staff and maintenance staff and housekeeping up to the doctors, and so there's an average in the cost. So that's why there's a formula they run. So you're running anywhere in the neighborhood of $23 million to $28 million, which would become a reoccurring cost, reoccurring funding that would come to the tribe to operate the facility on top of the existing money that is currently operating it. So that's the idea behind this program. I then ran it for increased funds because we know that the population around here is somewhere in the 30,000 range. We've been told by your census office and people that there's a lot more members of the tribe that live in the area that probably aren't using the facility. And my experience with joint venture and other new facilities is you build a new facility, the tribes run them, you tend to grow population. I mean, people tend to come back to the facility. So we think we could make an argument to IHS to approve at least 20,000, designing for 20,000. That would then give you this, a staff of 245 new people, $30 to $35 more million a year to run it. You could, if we could make it deploy to 25 or 30,000, that's what the numbers would show. So that's the idea behind joint venture, is if we could get that approved, get into that program, and then there's ways, we've been talking to some, like USDA has loan match, they'll give you loans to do it, and then you can pay the loan off with your third-party revenue. So there's ways to generate the money to build the facility, and then because of the staffing package that IHS gives you, you can pay for your staff, so that way all your third-party revenue that you get from Medicare and Medicaid and private insurance, those funds then can go to help pay down the debt. You're not having to use those to pay for staff because you're getting your staff paid by IHS. So that's the very significant piece about joint venture. Any questions so far? Yes?
Thank you. First, thank you for being here. Good to see you again. And thank you for asking for questions because I have a few and I didn't want to wait too long.
Okay.
But my first one, or the one I have for right now, is regarding the facility. You were saying something about determining that current user population went back 3 years. Now, is there any inaccuracies because of those pandemic years as far as like if this is our chance to expand or maybe starting off too small or using not accurate numbers?
These numbers, and I went back and I asked IHS for user pop numbers all the way back to 2010. And this number hasn't changed much in 10 years. It's fluctuated a little bit. 1 year it went higher, 1 year it went down, and I think it's right around the time there was real problems with IHS. Remember a few years back when they closed the ER and all those, there was some issues. It dropped, but then it's come back now. So this is pretty, in IHS's records, this is a pretty accurate number of users over the last several years. I think it can go higher, but that's a pretty accurate number.
So just like as a follow-up, because of the condition of IHS and all of the things like that, is there any way for us to put in our estimates for future growth that if we have a better facility, more people would utilize it?
That's why I ran the 20,000 and the 25,000, because I think we could make an argument, if we went through that process, we could make an argument to IHS to approve a higher number, just because they know there's been issues, they understand the issues, they know they know there's a lot of people that probably go to Winter or to Valentine or even to Rosebud or to Rapid City for service. And I think we can make a big argument that if you're gonna invest in a new facility, you want to invest in one that's going to last for a little while.
Yeah.
So that's why I think we could target 20 or 25,000. So.
And you're spot on with looking at how that adjusts. And so this plan, or this system, software system that's used, does look at what has been death and birth rates in an area and projects that. Again, it's tied to this number, but if we provide and settle on another number, then they'll have to reproject that out further. And because we know, we have documentation from the service unit here that they have 23,000 open active records on people.
Yeah, they have.
But over the last, on a rolling 3 years, it seems like there's only about 12,000 something that are actively using it. So the argument is, well, we want to consider who's not actively using it and recapture those people So we would not purposely try to do a design that's gonna be an underestimate. But it is a negotiation.
Yeah, so, yeah.
Very good question.
Yeah, you wouldn't want to build it for today's numbers, you'd want to build it for 10 years from now or 15. So. So when you do that, that's, when you see the number of staff, like 245, that increases the services. So that, when I ran this, and that's where you'd get into the planning, but I said, we want to provide all services, essentially. We wanted to provide whatever surgery. I always put it this way, healthcare is driven by numbers. I mean, you have to, the example I use is if you're going to do brain surgery, you have to have so many patients. You don't want someone doing brain surgery once every month because you want someone that does it every day. It's a practice. So the program runs based on the number. So if you put 20,000 users in it, it'll generate and say you need this many doctors and this many nurses and you need this size of intensive care and this size of labor and delivery. So yeah, it expands all those services out to what the health system planning program can justify based on a population. Because healthcare is really driven by population.
Yeah, and I would just say on services, as we know, IHS has been cutting services here. And just out of care, how many people were born at this hospital or have family members born at this hospital? Just,
At the old hospital.
yeah, so, and now nobody is, right? They took that away. And when we look at the Great Plains area, Sisseton used to have a hospital. Free Affiliated used to have a hospital. Rapid City used to have a hospital.
Right.
The trend in Great Plains area IHS is to close hospitals, and that's not good for our people. So they kind of start by cutting services like they've been doing. So, I mean, the timing is really important, that if we want to make sure that we preserve and reintegrate the services that our people need, that this is the pathway to do it. And I would just say also on joint venture, Flandreau did that very successfully, and prior to that, the Santee Sioux in Nebraska also did joint venture. So there's local tribes that have done this process too.
More? That's it?
I do have more, but I wanted to let anybody else if they have questions first.
And you also mentioned services, so when we transition back to the plans for the Rosebud Hospital, there's very integrated, granular information about returning services IHS has dismantled and stopped using the same staffing package we're getting today.
And I think that's what my main concern is, and I know I've mentioned it when I've talked in the previous meetings, but, and that's what the only kind of, like, I think, hearing about the good positive, like, I think that we're already sold on that. So to
Yeah.
me, it's like more like, well, what Rosebud specific and what we don't want or what I don't want is, either not being able to negotiate at all or being stuck with negotiating for our existing services that we know are depleted and that we know are not up to par. And so I look at these, numbers and that's great, but is that for the services that are currently being provided or is that with the expanded? Because I don't know if we've ever had that conversation about what our true need is and what our true goal is. And I don't want to be locked into negotiating for the current when our whole goal is to get us out of the current situation.
So what you have to remember is that, and I think Dr. Warren and them will address it, but when you negotiate with IHS and you take over a facility, once you take it over and you have then control to change what you want. So essentially you get the money and that's running it, and then you can make the decisions of how to spend that money. So that brings the decision back to you on what services you want to provide and how you want to prioritize those services and they're going to address it. It opens up the door to more funding too. There's other sources of funding that you can then do some more of those things. So that's the advantage. Because when you contract with IHS, you're not saying, I just want to contract for this service. You're contracting for the dollars, and then you make the decision on what you're going to provide and how you're going to spend the money.
I mean, I get that, but it also sounds to me like there's wiggle room for the government to come back and say, this is what we currently provide, so that's the value of it. Now do what you want with that money, when really what we're saying is we don't get enough money. We've been cut services, so we want the total need fulfilled.
That's a different topic, and
Yeah.
because we can cover one of the sheets when we get to it is the funding that's available by IHS. I mean, every tribe needs more money. IHS is only funded at 60% or something like that.
But,
So-
but for
I get-
example, like the
Right.
labor and delivery, we've had that before,
Yeah.
so we should have data and numbers and costs associated with that. So, but we
Yeah.
don't currently have that on our books and on our budget. So one of the fears is if we negotiate at our current existing services, we're not gonna get funds for that, and we're gonna have to cut something else
Yeah,
if
you
we
have to-
wanna provide that.
That is why the joint venture program is, the tribes that get into it understand why it's such a big program, because then it 100% funds you for all services. I mean, that's the idea there. You build a new facility, IHS agrees to staff it at that 85% number, and that's in forever. I mean, so that gives you full funding essentially right from the beginning.
But given that user population, the size of the building, already the commitment of spaces that have been designed into the hundreds of thousands of square feet, the opportunity to return labor and delivery is possible. And now, it would be nice if the government would come back and, well, the organization will staff it, but we have a model in here when you look at, and I'm kind of jumping ahead of here, but we've kind of identified a scenario of if there were 400 births a year occurring, what revenue would that generate? The staffing, the revenue generated is twice the amount of the staffing package to continue the service. So your third party is what's going to generate that. You know, given that the majority of these are going to be in Medicaid birth. So, and we've done that around surgery. So,
Yes, Jordan?
So do we have an actual dollar amount of how much IHS gets right now for the for Rosebud?
Yep. It's on that big
Is
spread.
it this?
And we
That's
can,
what-
I don't know if we should go over that now, but I can explain what that is. So that might be a good idea.
I mean, I understand it, but like, I guess I have the same concerns as Emily. I mean, I have a community member and their kid has to go
Yeah.
to dental surgery and they have to pay for that out of pocket because our dentists here don't even offer that. So I guess back to her concerns is, how are we going to be able to staff a pediatric dentistry when we've never had it? And with this dollar amount?
So well, let me explain that sheet. So what that sheet is, the long sheet is, that is what IHS and the tribal, Great Plains and IHS determined several years ago that that's the tribal share. So those are the dollars that are available to the Rosebud tribe that if they want to contract or compact for the services from IHS. The column that is called program, the first column, that is the dollars that are currently operating the service unit. The second column is called area. Those are the dollars that the office in Aberdeen uses, Great Plains. That's how they operate the area office. That's your share of the area office. The third column is headquarters, and that's Rosebud's share of the headquarters operation for IHS. You're entitled to contract all or any of those dollars. You'll notice, and that total sheet comes to like 43 million. The tribe has already contracted under your Title I contract for the ambulance service and some other programs that Skylar runs, about $4 million. So, and then there's a column called retained services, and I put a few items in there because we know that, especially IT to start with, if the tribe took over the program, they would want to leave the IT piece with IHS to start with, because they run our PMS, they run all that stuff at the headquarters level. So you'd want to leave your dollars there until you were able to transition to some other program. So it really comes down to there's about $39 million available to contract. You'll see in the middle of the form, there's a bunch of blank lines called Medicare, Medicaid, and private insurance. You can't contract for those dollars from IHS, but the day you take over, you start billing and collect those dollars. And as of IHS last year, they collected $22 million in those three categories last year. So you would add, and right now, South Dakota expanded Medicaid, so that number is on the increase. I looked at their numbers, we've asked for their data. They anticipate collecting about $1.5 million a month on Medicaid. The first 3 months of the October, November, December, they collected almost $1.7 million each of those months. So there, it's on the increase. So that 22 million, or up to 30, whatever the tribe would collect, that then is money that you use to enhance the program and run other parts of it and change it. They currently, like I said, they earned 22 million last year. They carried over, did I say 8 or 11? They carried over like $11 million last year, or 14 was it? Yeah. So that money they carried over $14 million last year, which they could have spent on other programs. But they didn't, and the tribe will then be able to do that.
And I would just say, so the questions really are, and real broad, how do you bring back services that were taken away, and how do we create new services that we need, right? And the way to do that is with new revenues. And, just depending on Congress to fund IHS with new revenue to do it, it'll never happen. But tribes have a lot more flexibility. So again, with the discussion, you can take all the money that you can from IHS in terms of the contracting or compacting process. But then all that third-party revenue in the future then is now controlled locally. The way it happens now, third-party revenue goes to Aberdeen first, then to here, right? You take Aberdeen out of the equation when you're under 638. The other thing you can do is be eligible for other funding streams that IHS is not eligible for. Right. So through HRSA, Health Resources and Services Administration, they fund critical access hospitals, federally qualified health centers. Because it's a federal program, IHS is not eligible for those dollars, but tribes are. So really the way to build new programs and new services is through 638, then you have more revenue streams and greater dollars to actually do that. So in my own experience at Gila River, when they 638'd the hospital there, they were missing all kinds of services that they need, but through third-party revenue and grants from HRSA, they were able to build a dialysis center, a nursing home, a behavioral health center, a diabetes education center. I mean, all kinds of things with new revenue. So it's not that we're going to say that IHS, this is what we need in the future in terms of new services. But we can generate a whole heck of a lot more revenue to just put those in place based on community priorities for new services. Yeah.
Right, exactly.
And I think a big part of that also is, right now, IHS is staffing a lot of their positions through contracts, and they pay a lot of money on those contracts. I mean, that's a huge expenditure where the tribe takes it and develops their own package and can pay their own salaries and negotiate different things. You probably can expand those services that they're spending on contracts right now. Because you'll see on there's a line item called accreditation or emergency or something. It's the one line item on the bottom for $13 million. That's what they're spending to run the emergency room over here every year, is $13 million in that one contract. So it's a big.
What are they bringing in for revenue?
Well, that could be part of their revenue, their third-party revenue. That 22 million is generated from that.
From the ER?
Yeah, they'll get some of that,
Yeah.
but IHS is actually funding 13 million into that contract. That's what Aberdeen told us. That's where that number came from. So.
But we are able to ask one of those questions. It's what is the service that's producing the level of income?
Yeah.
And really see what percent of that is coming from inpatient, outpatient, dental, pharmacy. Typically, pharmacy is like 50% of a health system's third-party revenue. And then what's coming from the ER services. Yeah.
We're back to another question.
Thank you. So as a follow-up then, in my experience with, funding and planning and things like that, or even negotiation, it's better to negotiate from a place of knowledge or knowing or having information. And so if we're expending this, we have an amazing team together, it sounds like we're expending money, that we seem to have funds to do that. So why wouldn't we want to then get our full vision plan out there? Because whether or not it's getting fully funded by IHS, it is then going to be used to leverage to go after more revenue generating, more funds, fulfilling that funding gap or diversifying that fund. So I just don't see why we are not looking into that right now. Why would that be an afterthought if we're going to be expending the amount of energy and resources that we're doing right now for this project?
Well, I think that leads to the plan of operation, that other document you have. There is some, the board has been putting together some strategies as far as what services they bring back, and I think there's another document there called Plan of Operation, and what's the title on it?
It's the plan for operating and improving Rosebud Hospital. So there's some history, and then it gets into staffing, funding, maintaining, improving current services. I think that's what you're identifying as you know, what are these near-term operational expectations that the board is putting on themselves.
And I think the health system board will be going through strategic planning here in the future of, you know, doing a 5-year plan, that's their job, but, you know, they're just in the early stages.
Yeah, it's in early stages, but you're exactly right. We want to have all of that information on the front end, particularly before going into negotiations. So in the process of collecting all of those data and making all of those plans. So our Chichango Oyate Health System Board has been in place just a few months, but we're planning on doing a robust strategic planning process and doing all those things that you're talking about, because we need to know all the dollars available and all the services needed. So we're getting that put together.
But they've already identified multiple priorities, and that was from the community meetings about surgery, labor and delivery, and expanding some other services. So those, go ahead.
sorry.
So those are stated under the section called maintaining and improving current services. And then looking at the opportunity for restoring lost services. And that's where our team has spent a lot of time looking at the logistics of labor and delivery, surgery. And then both of those are increasing the inpatient space at the facility. And so the assumption is, okay, looking at their average daily census today, how many patients they maintain, us looking at in year one, we need 10 rooms every day with a patient in it. And what would that cost? What's the staffing package? And what's the revenue plan around that? Because that's supporting, you know, the lady who's given birth and may need a couple days hospitalized, or that surgical patient, or that patient coming in from ER and not getting shipped out, but maintaining because you actively have a couple beds in ICU and more beds. Because again, this all gets to the urgency of staffing up the facility to meet those demands. So those are some strategies and priorities the board has sensitized itself through to commit to in the near term.
And just real quick to address your question about, thank you for saying it's a good committee or good people doing work, because we're working hard, but all the costs associated with this planning effort and all the way up to the day the tribe compacts, those costs are all reimbursed by IHS.
No, yeah.
So anything that we've spent through the tribe, the board, the consultants, attorneys, that'll all get reimbursed by IHS at the time you sign a compact. They pay that money back to the tribe. So, and they give you startup money. So any additional new equipment or some things that we will identify, they would fund that up front. It doesn't come out of your $39 million. That's a separate pot of money.
Mm-hmm.
And there is one other line item on there, and that's called contract support costs. You know, right now you'll see that it's in there. That's just what's associated with the Title I contract. So if and when you compact for the whole thing, I think your IDC rate right now is based on staff salaries. You would end up getting another $1 million to $2 million in indirect costs added to that. But that would get negotiated at the end once we decided what we were taking. But there will be additional contract support costs at any time you do that.
Yeah, and that's annual too.
And
So,
that's
and that's another huge advantage of 638 is that IHS direct services don't get contract support costs because they're not operating under a contract. So if you've ever had a grant that you get indirect cost rates, that basically is what the contract support costs are. So like he's saying is $1 to $2 million a year just to manage the contract. And that's new money that IHS doesn't currently have. So, and that's also, again, annual funding to help support just the contracting indirect rates.
Sorry, maybe you guys said it and I missed it, but does the contracting, do you get funding for the new facilities? Does that come along with it as well?
No, that'd be, so looking at the new facility, that would be under the joint venture process, is what we'd be looking at. I don't know if you had any more.
Correct.
That's a
Yeah.
set, you'd have to fund that separately. I mean, the compact is just that $39 million plus contract support costs. That's what's under the compact, the operations. If you built the new facility under joint venture and you got the new staffing dollars, then those would get added into your compact. So that additional 20, 30 million would get added in at that time. when you brought the staff on.
And also that line item, this contract support cost, and I think the tribe's at 23 point something %. And so you don't, that's based on your salary. So all new staff would be identified as what we call direct hires. So their salary and fringe benefit would fall into being eligible to increase that dollar amount through the contract support cost. As, you know, there were 2 days of meetings that IHS had with their staff, and they talked about the IPAs and the MOAs. So they're perceived like a contracted staff. So contracted staff, you don't get to apply that rate to it. So the methodology is the board and the organization will know whom are all of the contracted staff, and then as we can replace those with a full-time employee that's a direct hire, then that resource will annually increase that contract support cost. So it's kind of low in the beginning because so many of the staff are still IHS employees, and you're actually paying IHS back to have the privilege of having them continue their work here. I mean, gosh, they're a valuable service and they're providing great work for you today.
Chris?
Yes, sir.
So just so you know too, that staffing package, once it gets included in your funding agreement, is reoccurring from here on out.
Yeah.
It's not a one-time thing, it's included, you'll get that amount once it's included from that time forward.
And also in the IHS budget, as they increase payroll for their employees, there's a part of that that goes to tribal operations as well. And there's inflation adjustments and things like that. So, you know, though today, let's say, just to make it easy, it's $30 million over the years, as inflation goes up and as the cost of living wage goes up, the tribe would also be receiving that. So it's not something you have to go back and renegotiate and say, hey, we need that. It comes through the documents to you.
And I'd say you already have several 6-8 contracts already that have been in place for decades. So you already have local capacity for annual funding agreements and those types of negotiations too.
Is there any more questions, thoughts you need to share with our group?
I have questions, but I didn't know if you were gonna talk a little bit about the plan first. I didn't know if
think
you
let's
had
go
more of
back
a
and do-
presentation or if we were
No,
just.
I think it'd be helpful to go back and kind of go through
Yeah.
that section by section, even though we kind of jumped to the end of it, because it's restoring services, which is pivotal need in the community. So,
Okay, I'll hold off on my questions.
or hopefully some of them get addressed as we go through the process. Yeah. There you go. It's something that wasn't highlighted yet, but as we're seeing with the tribe's ambulance service and some other components, we broadly talk about South Dakota expanding Medicaid, but financially that really means something to a health operations system. And so we would look back at the IHS, let's say, okay, it was $2 million, $22 million. What part of that was Medicaid? And then actuarially, we could say, then we can apply an adjustment to that we're looking at 22 to 25% more in recovery. So that's 25% of maybe $15 million of that being increased third-party revenue, and you're not changing the level of service. It's because more people are eligible for Medicaid.
Yeah.
So it's increasing the third party.
Yeah. And I'd just say, so think about staffing, first of all. I know a lot of times when a tribe starts the process of 638, the current staff is worried, does that mean that they no longer have their jobs? And that's not the case. And can retain anyone who's in good standing through an IPA, interagency personnel agreement for commissioned corps officers, or MOUs, memorandum of understanding, for the civil service employees. So they can all be retained, and they all get to maintain their current level of benefits. So they get federal benefits, they get to keep all of that, as part of the 638 process. And this process has been done many times. It's something to keep in mind. We looked at the numbers. It's now over 60% of the IHS budget is managed by tribes now through contracts and compacts. So over 60%. So there's a lot of experience in doing this and going through the process. And of course, having people on our team that have gone through this process very directly. So that's one thing with current staff. In terms of recruiting new staff, there's of course a lot of vacancies, and another thing to keep in mind is that the recruitment process through IHS can be very cumbersome and very slow. And when you utilize basically state-of-the-art or standard practices for the private sector, it's easier to recruit. And actually, Skyla and I were talking earlier, you just opened up a wonderful detox facility, and it needed public health nursing and licensed therapists. She's already been able to hire 3 public health nurses, 2 licensed therapists, and an administrator, right? But basically just by going through recruitment, through using recruiting organizations that IHS doesn't have access to, because IHS goes through their own federal process just to recruit providers. So you're no longer locked into the kind of arcane way of recruiting or even purchasing things. Just if you want to buy something in IHS, it could take 2 years if you want to get a CT scan or an MRI, whereas under 638, you just purchase it. The other thing, at least what I experienced.
You better validate that you need it.
Yeah, you have to validate, of course, but you don't have to go through the federal hoop. So that part also gets easier in terms of recruiting. The other thing that I've seen tribes do because of more revenue, you can also offer better salary packages and benefits packages than what IHS gets. And when I worked at Gila River, when I was first there, it was IHS, and they went through the transition to 638. And just based on new revenues, they were able to offer anyone who wanted to go over to the tribal side a higher salary. So most of us did, basically doing the same work, but working for the tribe, the better salary because there's more revenue than just working directly for the US government. Now, a long-term strategy that I would love to see happen is that, of course, we already have a lot of vacancies, right? And that's one of the challenges, the number of vacant positions in IHS. But we also have a high unemployment rate here, right? We should be linking those together where we have a workforce that just needs training. And if we had a tribal hospital, you already have a tribal university, why not have it be an Indian health teaching hospital? And you can actually fill those vacancies by training up your own people to work in those places. So I think there's all kinds of opportunities with local control. Trying to do that with IHS is very cumbersome. And again, it's not the fault of any IHS employee. They're not responsible for the system. It's the system that slows down all of those things. So just in terms of staffing, those are some of the considerations. Just red tape, that IHS has to deal with, but working as a tribe, what I've seen is that by getting rid of some of the cumbersome federal processes and that bureaucracy, staffing and hiring can move much more quickly. Even credentialing can go much more quickly. So that's kind of on the staffing side, but I'll pause there, see if there's any questions on the staffing section of that document. Nope. Okay, I'll go on to the. Oh, sorry.
My thing with the staffing that I see in here is like, I guess I feel that it's going to be hard for us to bring people here, right? Like you talk about like Gila River and those other ones that are like 638, they're a bigger reservation with more amenities all around them. We don't have that within a 100-mile radius of us.
Yeah.
So I think that like it's not really addressed in here as like a challenge, but I feel like it is a challenge. I mean,
Yeah.
look at the providers we have now aren't the greatest, right?
Mm-hmm.
So I just don't see how we're gonna address that, I guess.
And then you're right, there's no large population center close by, that type of thing. But actually they've been able to do it successfully in Alaska, and a lot of it's with better pay. Our colleague, Dr. Kelleher, is actually from Nome, Alaska. They have a hospital that's fully staffed, and Nome is even more remote, than Rosebud. I don't know if you wanted to say anything about that.
Well,
Yeah.
just a couple of thoughts that I have. I really appreciate the question, and we do, as a board, spend time talking about this. I just want to reassure you that we realize that's a challenge, but also there's so much that you can do to address it just through this compacting process. For example, when I was hired at the Indian Health Service, they hired me at $89,000 to start as a physician for IHS. And that's less than half of what my classmates were getting paid. I was in it for the service, but really when I started working up at South Central Foundation, tribally run organizations, then you start at 160, 180, 200,000 to help pay off all of your terrible loans and help support our families, right? So just to give you an idea, that if you have a higher salary, it will attract more folks, such as myself, and I've experienced that personally, but also there are other successful models. For example, we were just talking with Dr. Plumage about the training in peer, and one of my colleagues from Alaska, actually, local lady. She's a teacher and a director of a residency program in peer, and I think that's a missed opportunity that we don't have a relationship at Rosebud officially yet with these other residencies, not just in South Dakota, but in the surrounding area. And of course, we already have some relationship with Boston doctors, but they're quite a ways away, right? So I think there's missed opportunities locally, and then also with these other organizations to help us recruit, so that folks, maybe you can have a cohort of folks, like a family of folks who come in and out and fulfill those obligations as we're growing our own. I hope that makes sense. Yeah.
And I think there's the opportunity. What does a community that's a quiet place, like a sanctuary, like you have here, what does that afford some people emotionally? That they're not in the hustle and bustle of places, and you have hunting, you have outdoor, and so it is the recruiting side of it. And it was interesting, I broke a tooth, so I had to go to the Cherokee Nation dental office, and it was an emergency. And the dentist was a young man that grew up in a rural area of Oklahoma, went to Creighton in Omaha, and I started talking about some of the work I'm doing, and I said, well, we're working with the Rosebud. He goes, oh, Creighton dental program has an affiliation out in Rosebud. I hadn't heard about it yet. So and that's, the strategic thing is, where are these? And then bringing those people out here when they're in a residency, in a training program, and it opens their eyes to, oh my goodness, there's an opportunity. I heard you on pediatric things that needs to get on there. But so it is that opportunity, and it's how you approach it. And I tell my peers all the time, because we do a lot of conferences, we attend conferences, and the self-governance conference is coming up, and the NIHB conference is going to be in Rapid City in May. And there's typically a booth there, and it's a lady, and she's marketing for the Cree affiliate tribe in Newtown, North Dakota, Elbow Woods. They hire her, and that's where she can engage with people, for them to learn about, here is an opportunity. So there's where is that crossroads and engagement where we can start the conversation and work? It's going to be a hiccup for the first 7 years, that's for sure, because there's a reputation out here, and it's the Indian Health Service's way of bringing and ability to recruit people, as opposed to an organization that have people on the board and some other consultants that have collaboration opportunities that can really jumpstart this. Because as we do our work, we're consulting practice, we're not on the day to keep the facility transfer over. We want to be here during the stabilization period. We come alongside you, this is your system, and we want to use all our resources to put in other resources here to make it sustainable.
Yeah, and it's a good point too, because if it's a provider who wants to be in a big city, obviously we're not going to be able to recruit that person. But look at the beauty here. Look at the outdoor activities, the things that could be actually part of a recruitment of potential providers. There's those who would love the, like you say, the hunting and fishing opportunities, even the outdoor activities. There'd be other types of providers. And then also, if it does move toward becoming a teaching hospital, there's a lot of physicians like me who really love to teach, and I wouldn't have that opportunity if I came here to work with IHS, but it could be that way here, if we move that. So kind of intergenerational and long term, I think that's really a solution. But short term, there's other things that we could do to recruit, including better pay and then really highlighting some of the benefits of being in a smaller community.
I just hope that we really get that chance, because our governor has a different avenue of approach with our reservations, and it's not always a positive outlook. And I appreciate you guys saying that. We have a lot of positive things here, because I believe so as well. But when the governor openly says things about our reservations, not just Rosebud, but Pioneers as well, our sister tribes, it's really disheartening. And then I just worry that those are little things that are gonna deter people from coming here, even though they don't fully understand, they don't see the full picture of it.
Yeah, I agree. And we're always going to be facing some of those political challenges at the state level, unfortunately. But I also think that the opportunity, again, if it's really focusing on teaching, you could have medical students and residents coming in here that would fall in love with the place. That's happened in other rural IHS facilities or tribal facilities. And it's one of the best ways to recruit is not just with a flyer or an email, but actually having people here. You know, but that capacity just needs to be built to help teach.
And Dr. Toombs.
Yes, please, Dr.
Well, I was just gonna give you a story about recruiting. Since I'm working here, post-pandemic, we lost our entire hospital staff. Everybody quit. They said, I'm done with this. I don't wanna do this ever again in my life. So we brought in a bunch of contractors. But by upping salaries, we now have a full staff hospital staff, all 6. Only one of us lives locally. That's me. The other 5 fly in from San Francisco or Miami. They come, they work for 2 weeks. And of those other 5, 2 of them have now moved to Central South Dakota. They said, hey, look, this is great. I want to be here.
Yeah.
One thing that they've never done is next fall, we wanted to see a powwow, so we're coming down to Rosebud there.
Yay.
So that's also a selling point. If you can get enough flexibility and income to move the salary package, they'll come.
Thank you so much, that's wonderful. I just also wanted to mention that at national leadership levels with healthcare providers and institutions, we are working to increase our health workforce in general. So there's a couple of national initiatives, iHeart and iHeal, the Indigenous Healers and Educators Alliance, and the Indigenous Healers and Educators Regional Task Force. And these task forces are made of folks like us. We just received funding to build out an online platform where students who are interested can look at training opportunities at places such as Rosebud if they had training programs here, and students can self-select to come to sites here. What I'm hearing is that we actually kind of need a national campaign to say, healthcare providers, have you thought about working in Indian country, right? And so I'm hearing that need, and I think we can make progress in trying that kind of a campaign, especially to reach out to healthcare providers who are in training and help recruit to these settings where it's a joy and an honor to care for our people. Yeah.
And,
Yeah.
you get a passion. Because we look at the statistics, and there are a phenomenal amount of very trained service providers who are aging out, looking not at retirement yet, but they are tired of corporate healthcare America. They are used as technicians, they're internists, and they're demanded, see that patient for 3 minutes, 4 minutes, 5 minutes, for the same pay, and moving to a calm environment. Some would come. It's not like we need 500 this year. You know, if we just could get 10.
Yes.
And they can make a commitment to stay. And something we had to do at Cherokee Nation is we had a strong stay with us incentive point. Corporate America, it's, hey, how many patients did you see today? And I'll give you a bonus at the end of 90 days. We've done a big carrot, stay with us another year. When we came to their annual buying, or 2-year contract. Here's $40,000, you make commitment to stay another year or 2 years with us. And those are strategies that are working. Yes, it costs, but you're maintaining the workforce and you're not paying a contractor. Or the other issue is, well, we just won't fill that service, we just won't fill the schedule. So now we're not going to have a schedule for 20 people times. You know, they're open 200 some days a year, so how many visits is that going to impact? So we keenly look at those operational things like that when we start assessing this. And we're collaborating with the American Indian HR Association to actually do our salary wage benefit package analysis. What would be the best competitive thing for us?
Yeah.
It's gonna be a price, but it's really, yes, ma'am, sorry.
Oh, are you?
Oh, yeah.
Okay.
Well, you stop me. I talk on. You just stop.
I just wanted to divert from the staffing
Mhm.
question and explanation there for a minute, but you know, in 2016, when IHS, we had our diversion, and at that time, they shut down our surgical and OB unit
Mhm.
so that our tribal members can no longer have their babies here in Rosebud. So on your timeline, if this takes over, how soon do you think you can open that OB unit up there so that the tribal members can start having babies back here in Rosebud?
Yeah, and again, a lot of that would depend on the joint venture, we'd be able to create more space to do that. So in terms of timeline, if it does get announced this summer, any thoughts from the team on like timeline for joint venture?
Well,
My thought is as soon as possible, I don't really know what that means. But
Yeah.
it sounds like it's a priority, that's what I'm hearing.
Yeah, it's been 9 years.
Yeah.
And, yeah, since our OB and surgical unit has been down, and that's a high need here, and I see it in your paperwork, how
Yes.
the good prospect and outlook of how much that department is needed, because it saves on our patient referral care money, right? And it keeps, our services local here without referring patients out, so,
it's our
so
son.
they refer patients out for labor and delivery.
Yeah.
But I know a lot of our tribal members would like to keep
Yeah.
their children.
Right. So our assumption is, today we've done a lot of analysis, but we're not to the point where we even have the privilege to walk through the facility. You could probably tell us better, what's unused space today? So,
Why is that? I mean, isn't that part of the assumption, is that you
Well-
get to walk through the facility?
oh, yeah, yes.
Let us know what is needed and what is not?
Yes.
Yeah,
And
we're,
what's the obstacle there from preventing that to happen?
because we're now at that pivot place of going through the next steps of the negotiation would be fully understanding the use of the facility today. So some of these programs that we want to restore actually make a priority and could be a reality. So our assumption is that we've not recreated that space for something else.
So are these numbers regarding the assumption, are they just an estimate, or are they, what are they going to do the actual walkthrough where the number will probably go higher, right?
It could. We tend to be conservative when we look at things and to step out and so, identify. I think we had some historical information that there are about 600 babies in the widow test at that
Yeah.
facility. And so we targeted, let's do 2/3 of that. Let's look at when that service could be deployed, that our goal would, in that next 12 months,
Yeah.
400 babies to be going. And then that's looking at giving the Medicaid birth payment to the facility, what kind of revenue will generate. So our nursing director went through all of these to identify how many of every position we would need to just start fresh. So we're looking at 400 babies.
When do you anticipate it? Or is that something that IHS has to give permission for?
Dan,
Yes,
any thoughts?
we would ask them that we want to spend several days here. I'd say we're at the point that is part of our next steps.
We're thinking next month.
Uh-huh.
We're walking.
As this moves forward, I mean, we see this as a tipping point of giving us permission to delve further. And so we didn't want to consume resource that is,
Yeah.
if there's a challenge.
If,
I agree, for us to
If
do our work.
IHS is reluctant to give you permission for the walkthrough, will that prolong it, or was it?
No, that I think
It just
they will be
doesn't give hard
welcome.
numbers on what is actually needed?
Oh, yeah. We'll request a date,
Yeah.
and that we're hearing, you want us to do that, yes, we'll put it on blank.
Yeah, and we know labor and delivery is high priority, so we do everything we
And
can
so-
to get it restored, even in the old facility. But that's high priority. Yeah.
Did you have more?
I just had a question, thank you. So since you guys are talking a little bit of the negotiation piece, I heard earlier you said, this amount that was on here, we're kind of stuck with that funding, but then I also hear that we're in stages of negotiation. So that's kind of why I was wondering if you could explain a little bit about what you mean about the negotiation, if we really don't have room for negotiating the funds. And there's reasons for that. I mean, one of them is we just heard like one of the big recruitment and retention opportunities is to increase wages. Well, then that is gonna come out of that overall chunk that we're already taking pieces out of. So in my mind, that would be a good negotiating tool to go back and say, because of our rural area, because of X, Y, and Z, we should be able to negotiate for higher wages. That shouldn't come out from our overall chunk. So can you explain a little bit, do we have that opportunity for negotiation or no?
And actually, from someone who's actually negotiated on both sides of the equation, it'd be wonderful.
Sorry, I should have been looking at you. Thank you.
We're gonna turn it over to you anyways.
Negotiation, unfortunately, the dollar amount's not what you're negotiating. I mean, you're really not negotiating a dollar amount. I mean, the dollar amount's on that page. You're negotiating that carryover money, and any money that IHS has in the bank, so the day that you take over, we make sure that there's a process that, an example is the day, if the tribe takes over on the first of a month, IHS is still billing for services prior to that. So as they collect money for all those services, they have to transfer that to the tribe. They can't keep any of that money. So part of the negotiation is making sure we have a pretty good handle on how that's happening. So that $14 million that they had in carryover, we want to make sure we get that on our side. So the negotiations are around that type of stuff. Scope of work, we will definitely have labor and delivery and stuff in the scope of work, but if you put something in the scope of work that's not possible right now, I just say you can't put that in there, because part of the scope of work and the funding is you're getting covered under FTCA, which is the insurance coverage. So when you operate it, your staff is covered under IHS, so the federal government, so for malpractice type things. So the scope of work is important to say that people are working within their scope of work. They're not off doing something they shouldn't be doing. So IHS negotiates the scope of work, they negotiate really the third-party revenue, any of that extra money that's coming in. And if there's anything else that the tribe wants to put in, because you have to remember under a compact, there's not a standard compact out there. There's some language that the tribe can put in there that they want about certain things. I could come up with an example or two maybe, but we would put some things in about the facility. If we decided that, an example is we opened up labor and delivery or surgery and we needed to update some of the equipment that hasn't been used for 9 years, we probably can put some of that under what's called startup costs and have IHS fund that before we take over.
Right.
And you'd make sure that you have that in your compact. Those are the types of things you'd negotiate. If they're doing any renovation projects right now, those we want to make sure get finished. The quarters, there's some things like that that get negotiated. There's little things like that that get negotiated through the process. If you decide to do MOAs and IPAs, you negotiate how you're going to pay for those. If there's any other services that you buy back from the agency, because you may have some buybacks early on, and then as the tribe develops and gets rolling, they'll do away with those and they'll be their own programs. So that's what you're negotiating. So the dollar amount's not what you're negotiating. Because IHS, through tribal shares, ideally, all the money that IHS has already been divided out by tribal shares.
So when we do services, we don't lose the funding?
No,
That's right.
funding's still there.
Thank you.
Very good point.
That's a good point. They didn't take any money away, they just changed how they usually does.
So the other pot of money, so right now, the expenditures are called pre-award, that's paying for services, that you get reimbursed that. In the next several months, we'll be building what's called the startup costs. And those are funds you get at the time of assumption, and you have 12 months to spend them down. And that's why it's needful that we go through, look at the facility, and if labor and delivery is an area that we anticipate within 1 year, we want to be having babies here. Well, if we just heard equipment hadn't been used for 9 years, it needs replaced. So all of that will go on this startup cost and create a budget where they'll be fronting you the money to buy the new equipment you need to operate the service you desire. So it's not coming out of your third-party bucket. But the IHS is always going to say, we have trouble managing, and this is how we get this facility staffed. Now it's your deal, do better on third party. And we see great opportunity to do much better on third party. And part of that is creating new services. A patient visit today Medicaid pay is $719 per visit. A pharmacy that goes out the door, $719. The more visits we see, the more pharmacy there is, and you see how that exponentially, the third party grows. It would be great if Congress, our government, ever fully funded Indian services, but that's not the times we live in. It's never been the times. That's where we can educate and work with yourself as tribal leaders to get involved in some of these things and be that advocate piece, because the staff within the facility, let's, you know, if they're paid under some of the IHS money, they can't be doing that. We got to rely on you guys to be that person. Yes, sir.
So you have your walkthrough plan in a month. How long is it going to take to put together that packet and whatever it is to say this is how much money we need to get this started?
Well, I would think, is your question like, how long will it take to complete this whole process? Because I think the walkthrough on the facility is probably a later point than some of the other things we have to address. Because we talked about, I mean, this whole HR piece probably has to be done first.
Yeah.
And we have to be able to hire people. So you have to have some of that. So our goal is to get that set up. Some of the contracting piece, because we're gonna you have to remember that if IHS has all these contractors running things now, those contracts expire the day you take over, so we need to make sure that those contracts have been converted over to the health system.
Mm-hmm.
And those people are working for the health system, so there's work to do on that ahead of time, so. In negotiations, the actual negotiation piece, once you send a proposal, it probably takes maybe 3 to 4 months to negotiate or to make sure everyone's on board with it. I mean, we're looking at probably now, I don't know, we're talking, usually tribes take over on the fiscal year or the calendar year, so we're probably looking at October, January maybe now, and by the time we get through everything, make sure we know exactly how it transitions, what all's gonna happen, because you don't want to take it over too early, because then you just have it all.
Yeah, that was like a concern too, that
So
you take over, you put in
Yeah.
this money, and then you find out there's more things wrong, and you need more money.
So we wouldn't do it until we get towards the end, but we'll initiate a walkthrough. I think we're right, we should probably do, my goal is, we've talked about this, really initiating is going back to sitting down the table through this data gathering with IHS. We're not negotiating with them yet, we're just still gathering information, which would be, let's go through a walkthrough. Let's get more data, because like the data I have right now, HR, for instance, was from, I think it was like July or August, but we don't want updated data. So you want all this new stuff, so.
And also,
Yeah. I think the target, I think the January 1st target date might be ready.
I also have another question to staffing, because there seems to be a lot of fear within the current IHS employees that are there. We have a lot of local people that work within that facility, and a lot of them are against contacting because of their fear, and they don't understand and know what's gonna happen with them. So when creating these employee packages, I mean, has anybody discussed these with
Yeah.
them?
Yes.
Yeah, we actually had a meeting at IHS for a couple days. We met with, met in the afternoon for the end of the day staff and then early in the morning for the night staff. And we talked about all these details. So, and again, the process for Commissioned Corps officers, it's an IPA, Interagency Personnel Agreement, so they can keep all of their benefits and everything that they've built up in federal service. And then for the civil servant positions, it's an MOA, Memorandum of Agreement. So again, every employee is kind of held harmless, basically, where they get to maintain all of their benefits and seniority, but then new hires would come under the tribe. And eventually, over time, it's all tribal employees, but there's a process to make sure that the current employees don't lose benefits or things that they've worked for.
so
We
there,
still need to make sure that they're informed, because a lot of them were uninformed, and then they weren't allowed or given the opportunity to come voice their concerns. So,
But IHS was at that meeting, IHS was at that meeting and.
is IHS's meeting, and some of our folks were invited to attend it. That is an IHS matter, and they'll have to have that meeting again, because you said maybe 70 employees?
Yeah.
I think between the two sessions. So, but the government has a responsibility to educate every employee. Well, that's, because they're gonna say, we need to start that 4 months before the assumption, so they'll get there. So,
The one thing that we have to do as the health system is, we have to develop our pay scale and our
Right.
package so that we can go to an employee that's, say you have someone over there that's federally retired or actually eligible, they may say, I want to retire from the government and come to work for the month. And then they become a tribal employee or a health system employee, and then they come up to retirement from the government. Or they may say, I have 4 years till I retire, I'm gonna stay under an IPA or MLA until I become retirement eligible, then I'll switch to the tribe. So it's the IHS responsibility to do that. We have to have our package together to give them an alternative. What would we pay them? What would their benefits be if they work directly for the health system?
so once we have that benefit package developed, nothing stops us from hosting evening sessions where if they have an interest, they can come and they can visit. Here's the job description, and here's the pay, here's the retirement plan, here's our insurance plan, and they can, if they're independent, to assess that.
Well, there's one criteria that some people get worried about. Hopefully they're not in there, but I think Dr. Warren mentioned, they have to meet certain, so the employees have to be, if they're on some kind of disciplinary action or something, they can't be IPA to the tribe. There's certain things that you can't, because our government's, if they're disciplining someone, they're not gonna pass that off to the tribe. So,
Just in good standing.
yeah, they have to be in
Right.
good standing, so there's, but there's very few of those, hopefully. And
Yeah.
if there is, then they can resign, and if the tribe is hired, they can hire them. So there's options.
And sometimes through our process, we identify that they're employees that are hired at the IHS, but they're a federal employee. They are on a performance plan. But if the tribe has the willingness, or the health system has the willingness to hire them, then we would make an independent offer to them.
I was gonna say, Dan, were those sessions recorded at IHS? Because so they're actually recorded. So each one lasted 2 to 4 hours, basically, and lots of questions. So those are recorded and available. And if there's additional questions, we're more than happy to address them. But yeah, all that discussion happened at IHS, again, with more than 70 employees, plus it's recorded, so they should have access to it.
And the intent was to inform employees about their status and the options that they'll have. But then the questions the government got, or Don and Dan got, and President Herman was there, were about protocols around procurement of stuff. So you start hearing from the doctors and the dentists about, it takes me so long to get, and then they use the paperwork, and then so it's kind of like, we thought this was an employment issue, that these are individuals who are really having struggles with just having the resources and the tools to do their job. So we address, we have our own procurement. In fact, that's one of the actions the board will be taking pretty soon, is the procurement policy and procedure. We have the HR, we want to have it legal reviewed. So there's some of those fundamental financial policies and procedures. Okay. Well, thank you. Great question. Yeah.
Thank you. So I have some questions. I'm trying to think if I can ask them all at once or if I have to do them all separate. But it kind of has to do with, I guess, the timing of things. And this might not be even directed at you because I know you're contracted to do work for us as a tribal nation here, but it's been come to our attention through resolutions and motions and, just things from our community that they were not really asked about this, and they would like to have a say. And so we have some things that have been brought forward to us, actually asking for that to be on the ballot this summer at one of our upcoming elections. And is this something that we really want to do? And so it's kind of hard for me to sit here in these discussions of planning for something when in the back of my mind, I don't even know if our people want to. And so I guess to get to a question, I heard somebody say somewhere in this presentation that, one of the next steps for the board is going to be strategic planning. So again, I'm like, where are our people in this? How can we ask you to act on our behalf if we don't even ask our own people what our need is first? So again, like, why have we not taken a step back and said, hey, we need some strategic planning within this nation. These communities within this nation need to be asked and need to have their voices heard before we can ever decide what's best for them. So is that a part of this process at all? Are we beyond that point at this point?
We're not beyond that point, but we are at, I would say, in the late spring and summer, our plan was to execute a community needs assessment. A tool that they would go out to the membership, and that would be their opportunity to be answering questions about this and that. So it kind of structures and identifies, here's the gaps and here's our needs in my family. And then utilizing that to help build the reference point of what are the other challenges that we're assuming some of these near term is what we're heard in the community meetings. We need to address surgery. We need to quit leaving the reservation just for basic health care, having a baby. So that's why the board at this point has adopted those priorities. But that's not to say that there's not the future to have a more deep think, strategic planning around some other types of deployment of services that will meet the needs of the community.
Well, I'm glad you brought the community meetings up, because I think that that was a good first step, but that can't be the only step. And I think that when at least my thought when I'll be making that decision was our people need to be included in this process and they need to be educated in this process. And so to hear you say you were gathering data, like I get that that's important as a process, but in my mind I thought we were providing data to our people so that they could be by. And I understand why it wasn't done is because we don't have it. And so again, that goes back to my point is when are our people going to be part of the strategic planning or be asked about what are, because waiting until it's already happening isn't working. And so, and this leads me to another question as far as like, how long has this process been from the start of bringing you guys on to date? How much funds have been expended in that? Because I'm looking at a 9-page document, including the cover sheet with no associated budget, with no associated cost, with very little timeline of history of what work has been done to lead to this point. And so again, I'm trying to see what the value of what has been done and why haven't people been an afterthought through this whole thing? And again, maybe that's on our own tribal government, I don't know, but.
I could go back. So we did on the previous tribal self-governance grant, we did engage quite a few community groups, like the veterans group, elder nutrition, the diabetes program. There were probably about maybe 10 or 12 community groups that we talked to as part of the initial study. And then I know since that time, Skyla and Dan have been out to multiple community meetings to engage the community about the process. But I agree, it's an ongoing thing. It's not going to be just a one and done. In truth, it should be ongoing discussions throughout the process. So I don't know if Dan or Skyla had any thoughts just in terms of the other community meetings that have occurred or maybe plans for additional discussions.
Well, just like, the only thing that I know right at this point is just we're under the direction of President Herman on these kind of activities. So we're following the lead with Chris and his group on that, which is part of what's in the grant activities, which is the community assessment piece, which he is going to be conducting here, whenever we get to go ahead with that. So.
Ben, did you have a thought?
Yeah, I had a good thought here.
Michelle?
Thank you. When you guys are coming, you guys getting back to Emily's question here. I had a concern because in my community, my name's Ben Thacker, the District Council Representative, we had a meeting, regular committee meeting that we had every month. It was discussed in there about this compact area contract. A lot of people at that time that were in the community meetings weren't supportive of it. I mean, they weren't really that understanding of it. And then after we came to the council, we did come that we wanted to go out and have some kind of an educational type thing to each of the communities. And I did meet with Skyla. She did come and tell me that the people that came to the two-track community, they wanted it, So I was like, whoa, that's kind of confusing to me, because in our regular scheduled community meeting, the guys that were there, they didn't want it. you know, and then she went out there to the educational part, and the people that came there, they wanted it, you know, so now here's my community, we're conflicted right now, you know, so how do we go about that, you know? Now, of course, it's easy to say, well, there was 20 community people at the meeting, you know, so why don't we just take them, because there's more of them than there were at the education part, but, I mean, in reality, yeah, we do have to go out, and I'm always an advocate of making sure that people, the public who are watching, know that they do have a voice, are able to, you know, get this kind of process, whether they want it or not, so, that's just my comment on that, because again, it goes back to the community part of it, and again, that's who we're representing, and that's kind of where I would like to get my decision on that. So those are the things that I had, but thank you.
Yeah, it makes sense. So continuing and ongoing education, really important.
Michelle, you have a thought, and then we'll get the floor for a community member back there.
Thank you, gentlemen, for coming and medical issues. I've worked at that hospital in the 70s as a security guard, and I've seen a lot of ups and downs there. And I've seen the medical cards, I've seen them complain, I've seen them ship out doctors, pick on the service room deck. It was my job to hear everything and try to help everybody that comes in there. We need and some nurses and doctors just think they're gonna just get through there and pay off their whatever education loan and go through. We hear all kinds of innuendos like that when we're sitting listening to the public come in and out. And some of it was true, some of it was just innuendos. But we need a communication. We have what's a community? They sit down, they talk, this and that. And when it comes down to it, there is nothing between the hospital staff and the people out there, and we need that. But the gentleman said, train some people to go out there and get a better communication. Oh, they're just there to pay their doctor bill off and all that. And one was like that. But I've seen it firsthand, because I worked in the 70s, 1970s, I think, I watched the two hospitals, I was service student director. We do have, it's very short because people come and there's so much to change of bringing non-elderly Lakota people. We never trust anybody, the old people. And the younger women, we didn't want to go to our grandma said, no, we're gonna die for sure. That was their attitude, and it's still that way today. We need that trust and build that up. Pitch was good, but we need more. We had people come out to the community and talk about it. Sure, you can hear some maybe positive. At least we're getting someplace. You know? That's better than nothing. I just wanted to. Because I have experience it. I worked this, so I know what goes on.
And thank you for that. And you know, going back to the 70s, I hope you've been able to see the video that was made in 1973. It's called Healthcare Crisis at Rosebud. Have you guys seen that? It's on YouTube. So just go and do a YouTube search and find that. But what they were talking about in the 1970s are a lot of the same things we're talking about now in terms of not enough providers, not enough resources, not enough services, and health disparities. So I just see this as an opportunity to make sure that in the next 50 years we're not saying the same things, you know, that there really is an intergenerational type of solution. So, but thank you for that comment.
Michelle?
I know that you guys have been going out to different communities and giving information and having all these different sessions, but there's still a lot of tribal members that are uninformed, and being uninformed brings fear as well. So there's a lot of people that are not supportive of it. Then we hear it, being on council, that no, we don't want that. And I think what would really be helpful is that if you can maybe type up a pamphlet, pros and cons, because you know those pros and cons, and hand them out to people, put them in their mailboxes, because not everybody can make these community meetings or these sessions that you're having. And a lot of people don't go to their community meetings, so they don't know. Just trying all of these efforts to get people informed on both the pros and the cons of it. There's a lot of questions, and while we're giving up our treaty rights, why would we give up our treaty rights? That's a big thing that I hear all the time. So I think these fears need to be addressed. People need to be informed. The employees are afraid. There's a lot of fear. And I think even if you could just type something up, put it in their mailboxes, hand it out to whoever. I mean, you can have it in Lakota, the language, so the elders can read it and understand. Just giving suggestions
Yeah,
on
that-
how to gain some support on it.
Yeah, that's a really good idea. And there's already other communities, other programs have done like frequently asked questions, or like you're saying, pros and cons. I think that's something that we could do through here. That's a really good idea. Or even social media if we need to record things, and because not everyone can attend the meetings in person. So the more we can do for education outreach, the better. And then just because we hear that, I've heard that in other communities. From Kyle and in Pine Ridge, talking about loss of treaty rights, and it's interesting because, in Rosebud, there's been 6 or 8 contracts for decades. The treaties didn't go away
But
because
not
there's
everybody knows that.
Yeah, isn't it? Yeah, so that's part of what we need to do then, is that 6 or 8 has been in place for a long time for a lot of services, So
Yeah.
that should be part of the information, the background information.
In regards to what Michelle just mentioned, we had the health board come up to our community, which is my community, which is Swift Bear up at White River. And they had a really good session, but there again, we only had 20 tribal members there.
Yeah.
And there's 300 or 400 in the community, so we can say there's 300 that didn't get informed. But they did do a really good job. They answered everybody's questions that was there at the meeting, but it was just the numbers. 20 people were there, and we'd like to have the whole community there, but that's not gonna happen either, so.
So maybe recording the sessions or something, have it on a website or something.
Yeah. And we have several, in fact, I was on y'all's website recently, and they had the facts and questions posted on the website for the health situation. And then we have it's not a transcript, but IHS took the questions and they provided us with 5 or 6 pages of questions from staff. So there might be a couple different information pieces to put together based on where people are at that would be helpful. And as the tribe, put something in the paper, or they do a general mailing or something like that to address these.
Even like what Emily said, even give the history of it, because
The-
people feel betrayed because they didn't know about this. We didn't know about it. I mean, we came into it and it's been going on for a while and nobody
Yeah.
knew about it. So the more information you give, I mean, it'll help people
Mhm.
with their fear.
I mean, there's a whole library of
Lila.
documents out there. But do people have public access to it?
Good afternoon. Thank you for coming, Diane, and I welcome all of you to Rosebud again. It's good to see you.
I'm really glad that you guys came and you're here talking again, because this is what we need. Before we got started today, I had an elder come up and kind of give me some concerns of his, and they're valid concerns, and we always revert back to our treaty, and this venture here that's happening, it is huge. It's never been done here in Rosebud before. So, sorry if we're not all with it, but it is scary. It is very, very scary for us to change. Even though what we have is not good, even though what we have is what we've accepted, it's just the way it is. But right now, on the reservation, we really have high number of cancer, very high number of cancer. We've lost a lot of relatives from cancer. We have people getting diagnosed with cancer. It's just like a norm again, and it shouldn't be normal, So I know there's ventures with what Skyla and them are doing on that issue as well. But sitting here thinking about, all of this, I'm looking at all the paperwork, and everything sounds like boom, 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 it's gonna happen and we're gonna live happily ever after. We know that's not gonna be the way it is. But, excuse me if I have to sneeze here, I caught a Sorry. There's a whole bunch of doctors here, so I
Is there
can
doctors?
Can anybody treat me? But you know, there's, the pros and cons is what, you know, with what my cousin over there brought up is really important. And that's what the elder asked us to do. He said if we could see it, show us what are all the pros and cons, and you have it here on this plan for operating and improving Rosebud Hospital. This is the information that needs to go to people. We have voted to put it on the ballot, you know. But you know, it's not that we don't want better. We are just so scorned. We are hurt and we're scorned and we're tired of it. And you know, now that it's this generation here, we have to look forward here. What can we offer that's better? What can we do that's better? And you know, going up here, just for this cold I have, I had to go to the ER because I can't get in the clinic. And you know, that wait is longer and another wait, and so we dread getting sick. We dread, you know, all the health part of it is being sick. But you know, we have a lot of traditional healers here as well that our people do utilize. And looking at that, you know, that's another venture that needs to be told, that you will also have this option. If that's what you want to do, you'll have dual options. You'll have all these options as a patient. So I'm sitting here thinking, you know, you guys are doing all the top dog work here, but what are my options in all this? You know, I'm alive today because I just saved my life, you know, so I give them that. But that's when we had a surgical center here. We had everything functional. And all of a sudden today, it's just, you go in there, get your meds, and you're out. Yet, we have optometry, we have dental, but you know what? I don't even go to those places because I know I'm not going to get the help. And you know, even being a diabetic person, you know, I don't go to those services. So we make those decisions for our own selves of what piece we're allowed, until we're absolutely so sick that we get there, and the outcome usually isn't good. So those are the fears that our people have, and they're just, you know. But like you said, we've been talking about these things since the 70s, since I was born, you know. And we talk about money, you know, money, 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 money. But in human life, all we have is our health. And we are not anything or good to anybody or anything if we aren't healthy. So I really think that in order for our people to give them their right to decide what they want for health care, we need to do this better communication. You know, I feel, you know, I'm at fault here because I'm still learning as well. But we need to produce those flyers. Nowadays, things are different, but we still have our people at home who listen. You know, they listen to the radio, they listen to and watch us on TV. That's who we need to reach as well. The ones who don't go to the community meetings, a lot of them, they just, you know, rather hear it from us, or what I've been asked is, do you have something that I could read? You know, so I think that would really be a good idea for us to produce that. And I think the other thing with that too is that maybe you can record something and they can play it on our radio. You're more than welcome to do that as well. But you know, I think what I have here and what I need to do for my people is to give them that. You know, so they are well informed and they know what their options are. So, you know, just putting that out there, but this is really good information of the pros and cons. The vision statement, put that out there as well, and work with it and go from there. So that's my 2 cents. Thank you.
Wopila, Lila Wopila Tonka, thank you so
Oh.
much. And just several things that you said really resonate. So for example, you talked about higher rates of cancer. And we think about cancer control, it's public health and medicine. And, you know, I've worked with Skyla and her team in some areas, and I know sometimes it's difficult even getting our own data from IHS within the community. Isn't that amazing? That tribal health sometimes has difficulty getting data from IHS right here in Rosebud. So when you have a 638 where the medical services are also under the tribe, then you don't have those barriers, you know, because cancer control really needs to coordinate across things like public health, prevention, and screening to treatment and follow-up services. And you can just do it in a much better way under one umbrella where you're linking public health and medicine together. And we've seen that in a lot of other communities where that's effective. You'd also mentioned traditional healing. When I worked at Gila River, they had 5 medicine men on staff. Isn't that wonderful? 5 on staff. So people could refer to the traditional healers, and some of them were comfortable coming into the hospital to do their work. Some would rather have the patient come out to their land for ceremony and that type of thing. But IHS wasn't doing that, but the tribe did, and that's something, you know, should you want to go in that direction, that's another option, because I agree that we have so much strength and beauty with our own way of medicine, and we're not utilizing that the way we could, you know, but the tribe can, you know, under that type of system.
Doctor, can I interrupt you?
Hello, my name is Garrett. I represent Sioux Fair. I just have some questions. Where you guys have your own electronic remittance system?
What now?
Electronic remittance system, where you have your own ERA system, or, you know, I'm just, the business pitch, you know, you guys sound really good and stuff, you know, and it does, it sounds awesome. But all these tribes that you're working with, they're all very little tribes. We have 30,000 people here. We have a healthcare system that has been failing us since I was born in '77. So, you know, as good as it all sounds, you know, you're gonna have to come a little stronger than that. The community meetings were awesome. I didn't attend mine, like you said, only 20 people show up at these, you know, 30,000, 20 communities times 20 people.
Yeah.
That's only less than 200. So that doesn't really tell you guys anything about our people, about how we are sick, about our needs. You know, I had a nephew that waited 2 years for a referral just to get a back x-ray in winter, 50 miles away. So, you know, the levels of healthcare are deteriorating, even as we speak. I have some relatives. She is in the corporate world, and she does the accounting for Summit Healthcare out of Salt Lake City. The Northern Utes have recently switched over to what you're trying to bring here to us, and they, you know, it's a Section 8, and they're doing very good. The Navajo Nation is also might venture up with them. So this is a Sichungu woman who's running this. And so, you know, she's my cousin. And so I'm very proud of her. And she has a lot of questions for you guys, and I wish that, you know, we could bring in the public, because this is a meeting that requires a lot of people, not just us 20. It requires the whole Sichungu Oyate to decide healthcare. With the Snyder Act of 1921, that's when healthcare got put on. You know, it always keeps getting put off as treaty rights, but it didn't come in until 1921 when they couldn't appropriate any more line items for us.
Yeah.
They had to think of ways to spend that money. Oh, let's just blame it on the Indians and their healthcare. So, you know, we're looking at a system that's been flawed since 1921. So these questions that my colleagues have are very serious. And I think that the health board, even from the prior council, they should be present here as well, because they had a lot to do with these decisions that you guys are standing in front of us with. So, you know, I just want to know that with the intention that you guys bring to our table today, 20 years from now, you know, like Emily had mentioned, you don't really give us timelines or any set numbers of what you project. So with your whole project, you know, what are your numbers? What do you guys tend to make off of the Sichungu Oyate in terms of Do you plan to make us healthy, or do you just plan to retire well? You know what I mean? So these are all just questions that we out there, we're all getting questions buzzing in, you know?
Yeah.
Right now, get another question.
There you
So
go.
this is a very, almost controversial meeting today. And we only had quorum.
Yeah.
So it's also not very comfortable, so to speak. You know, we don't even have our tribal president here today. So it's, you know, this meeting, although it's monumental, raises more questions than there are answers for. So I just wanted to add that. Thank you.
Yeah, and thank you for the comments and all of the ideas, because there's clearly a need for more education and more engagement. And I know this session is recorded, so that there's going to be information available on the website, you know, for the recorded meetings. And all the meetings that we've had have been recorded. They should all be on the YouTube site, right, for all those discussions that have happened. But I do agree that there needs to be other strategies to make sure everyone who wants to learn more has the opportunity to learn more about it. And then just in terms of, you know, the meaning of this, I mean, for me personally, this is sacred work. I mean, this is about the health of our people and the health of future generations. And honestly, I don't want to see us in the time of my grandchildren that we're having the same discussion about the challenges of lack of resources. We should have a thriving and effective healthcare system for future generations. And to me, you know, it's not about me personally or anything. It's about future generations. And it really is sacred work that you are all doing, that we're all trying to come together around. But I agree, the education strategies need to be more diverse to make sure we're engaging more people. Yes.
Lila?
I wanted to bring up one thing when we talk about communication and being, we always talk, love one another, find a way. Reasoness, being jealous of each other. When we get together and then when one of the community chairman gets in, then just his time he should go. The other one gets mad to stay away. This is, I can't, politics or whatever, but this has been our way of life. Always will be. I don't know what causes it. We need more, like you said, radio pamphlets. Because I don't think you could ever, once I present all these members of the community, you're going to have to say, well, all of them have some mean faces. I don't know if you lived around Indian country very much. If you did, you should know that. But there's a lot of politics where it comes change to administration. We see it here. So keep that in mind when you talk about trying to communicate with the people. I don't know how to do flyers, tell everybody gossip, every lot of radio type stuff, but a whole network.
Lila?
I forgot to add something, if I may. I would like to throw my request in, even with this body, and I would recommend for you as well, Dr. Warren, that we bring on translators, our interpreters. That's very crucial because our language still thrives here. And for our elders to, just having that talk this morning, it really, you know, touched me because this elder took them time to come here and tell me their fear. So I would ask this body to think about that. The next time we meet again, we should have an interpreter here. Somebody who can, you know, add that going. I mean, this is really big. You know, to me, it's like bigger than the shrine circuit, you know. But it's important that we include everybody as much as we can because, you know, my respect here is what you all have sacrificed. Being native, to go out and get into the field of medicine. I can't imagine the challenge that you all had. You know, we come from poverty, we're born into poverty. And that mindset, you know, somebody there in that gift of healing, that gift of you being here today and us helping our people. We want better. We want to live, you know, and it's taking our own to make that happen. The other part to this is that our children. And it always sits in the back of my mind, maybe not to many, it doesn't make a big difference. But I worked with child care, child welfare. And, going in and just listening to doctors and, treating children as well as my own. Our dental. If a child does not have the proper dental work, that affects everything. So we need our dental office. We're all over, and it's really tough. And all of this needs to be here because we need to give our children that, as well as our language. So I think council, we can probably talk about that and how we can bring a translator here, interpreter. It's really important to do that, and maybe you all can talk about that as well too. So when you come or when you go someplace, you take someone with you. That'd be really helpful as well. So, all right, thank you.
Jordan.
Just to kind of follow up, when this first came about and I was first hearing about 638 in our hospital, I was really excited. And then like Lila, when elders come and they say things to you, then it like makes you really step back. So I think that we have a lot more educating that we need to do in that aspect, because as much as I want to sit here and say yes today, it's the same elder today that talked to her came and talked to me outside, and it just kind of like makes you take a step back from it all, and hearing that they're so scared because it's a treaty right, but you're trying to like everything that I know, I'm trying to explain it to him, right? And it always doesn't get across though in English, right? But those are just kind of some things that I get really hesitant about, because I do know our people deserve better health care, and I feel like this is the only way we're gonna get it. But it's just getting our people all the way there to believe in that, and that the tribe is willing and is capable of taking that responsibility on. Because as much as it's a treaty right, the tribe has to be ready for it as well. And I feel like that's also a breakdown, because we've had tribal businesses that have failed once the tribe took them over. So I guess we really need to figure out how those go hand in hand and do that education before we can fully get the trust of all of our members to really say like, okay, the government is making a decision for all of us and we're okay with it. But I don't feel like we're completely there yet.
Emily.
Thank you. I'm just gonna sit, sorry, I can see my questions better. So that brought up a point, I guess, for me about, the trust and just everything everybody's been saying today, and my questions even before, but I just want to start by saying, I don't ask these questions because I'm totally against it, and sometimes I come across a little bit harsh and people, put up walls, and that's not it for me. I'm new to this. I'm taking this responsibility really serious. I have a little bit of background knowledge on it, so I'm trying to utilize that as well. And so like when I first heard about this, I didn't even know it was already in place when it was, we got in September and it already happened in May, and there's no knowledge to none of our people. So unless you were on council, you didn't know this was even in existence. And so like when we talk about timing and we talk about including our people, like it was explained to us that the thought was they wanted to remove the politics of healthcare. And I can see that. I totally get how politics can somehow hanging up. But as I was learning and hearing about all these things, we didn't remove the politics, we removed our people. We went from having a say from our voting, from our council to our health board, to having a whole new health board that oversees not only this project, but like 11 or so of our programs. So talk about trust. I mean, this is the first time we've met you guys in person. We haven't even met everybody. So how are we supposed to say, yes, we turned over our responsibility to this whole new health board when we didn't even know about it? And yet, how are we supposed to educate our people and let them feel like they're part of this process again, when they never even knew about it? So it's like very, almost borderline disrespectful for us to be having these conversations when they think they still have a say, yet we're moving towards the thing that we already made that decision. There's things about audit decisions. There's so many things that affect this timeline that it's almost a disservice to talk about them without, being out of context, because the timeline's affected by that, and if we don't do one thing, that's gonna hold up everything else. So even if they're on a date of January 1st, to me, that's, like, are we sure about that? Thank you. So she's giving me my warning, I need to wrap it up, but I guess what I'm trying to say is, how can we keep our people in this process? How can we make sure that we're allowed to question things without saying we're gonna ruin it or we're gonna stop progress? Because I'll tell you personally, take this hat off, and me personally, I 100% see the value in compacting, contracting, whatever we're gonna look at, but also me personally, I feel like we're missing several steps from there to there. And one of those most important part of the step is our people. And so again, how can I sit here and say, I'm doing this for you, I know more than you, without them even having that say. So I have like 30 seconds left, so I was just wondering if you could also touch a little bit on that question that wasn't answered earlier about how long has this process been from start to finish to date right now, and how much money or resources have we spent? Thank you.
Yeah, and just going back to the informing people and making sure that it's an open discussion. I think all of the council meetings where we had discussions have all been recorded and should be on the website. So I think with all those meetings should be there. And Dan, I know you've been involved since the beginning of the process too. Do you want to address the timeline in terms of when it all started? Because I know there's been several starting points, but then the pandemic got in the way of one of them. So if you could address that, Dan.
Yeah, sure. I've gone over this before. I was trying to remember. I didn't bring my notes for the timeline. But 2015 is when the first study was done that tried approved, and Evie was the one that was in charge of the health ad at the point. She initiated that study, and it was that's what started everything for this whole 638 process. Now the 638 taking over the hospital, 638 and so forth has always been in discussion for decades. But this is one of the first real actions that was taken by and initiated by somebody. And so that a grant, a TMG grant was awarded, and Evie was the one that got that and initiated the study. And the study was pretty good. It showed the lack of IHS's ability to manage the hospital. It showed that there's 13 CBOs revolving in at the hospital within a 5-year span. So it really started everything with this whole initiative. So that moved on to a couple years later when it was not the council at that point, and I wasn't here, but the council at that point just tabled it, didn't move on with it. So a couple years later, Tori Whipple applied for another grant to continue this effort, continue this initiative, and it was awarded. It was awarded by IHS, and that one was for the evaluation of the hospital and readiness survey. Now that got postponed because of COVID, so it got delayed another year, but it was completed, it was submitted to the council. So then at that point, the question to the council by Rodney was, what do we do? Do we move forward, or do we just table it again? And he said he wanted to move forward. And then that's when Skylar came on board with at Health. And so the next application or grant application was submitted, and that's the big grant, which is like $325,000. The other grants are only like $120,000. So that grant application was submitted, and again, IHS awarded it, and it's a 3-year grant, and that leads you into the final phases of compacting, and so that's where we're at now. But in terms of planning, and initiatives and so forth, we've gone further than from what I've seen ever for our tribe. And that's what we're here today.
Can I just address, I mean, I made the comment on January 1st, and part of that's because I'm an engineer and I like to plan. But I also am very aware that when a date gets put out there, people freak out. And to me, in order to keep moving and gathering data and making decisions, you have to have a target. But the target can move. And I look at it as we say, okay, January 1st, but then in 2 months we reevaluate and say, hey, we may have to make that March 1st or sometime the next year. And I'm always afraid, yeah, you've got to be careful we don't go out and say, yeah, we're taking over January 1st, because that's not what's going to happen. But as far as trying to get work product done and get work meetings and discussion, okay, you kind of have to have, if we say, well, we're not going to do this until 2026, well, who's going to put together FAQs and send it to the community, because the community is going to change the next 2 years. So that's the whole idea behind having some realistic target, but it's not fixed in stone.
Thank you for that clarification.
No, it's just more about how we can plan work and try to get some of these questions answered.
No, I appreciate it, and I think that helps for educating our people too,
Yeah.
because that is a common
It's
question, is the
not-
timing of it, and so I think that.
That's not going to happen. If that happens, that's great, but by then everyone will be educated. Yes.
Thank you.
I'm sorry, I just wanted to say one more thing. In all honesty, I just want you all to know that I have received no compensation whatsoever from Rosebud Sioux Tribe, and I do expect that some of my travel expenses will be reimbursed for attending things like this. I'm hopeful of that anyway. But I just wanted to be in full transparency, just let you know I have received zero money, and am here out of service.
Thank you.
I guess for me, I guess what Anna was talking about too, in order for us to get this information out there, I would like to have maybe our Skyla, maybe do a little deal with Dan, I just said, all the process of this and when, because again, when it comes up to us, you know, I wasn't aware of this either, like Anna, we just came in here in September and we found out what's happening, but I mean, if you guys come here, I understand that, you know, it's a good, great experience, but I would like to at least find out when it started, you know, how this has come about so that we know where we're at right now. So that's kind of what I was hoping that we could get from this also too, is the timeline of where it started, how it's come about, and then is it feasible. So that way our community members or tribal members can actually have that understanding also. I mean, and again too, if we don't, first thing you think about is treaty rights, and then all of a sudden they're done. Like, no, we don't want that, you know. So like my parents, you know, again, thank God they're still alive, but that's kind of one of their concerns too, is that, you know, the treaty rights and also, we had this all these years. We've had IHS here all these years because that's what was owed to us by the government. So all of a sudden we're changing. So we change something, they don't have a direction of what's going on, or nobody's telling them exactly what's happening. So when they don't have that, they're just going to follow suit and just not go there anymore, not do anything anymore. So again, even to this day, you know, when you go to IHS and get treated rudely there, they're not going to go back for another month or two because they don't want that same treatment again, you know, until they really have to go back. So these are some of the concerns that, again, that are going to come up in the public anyway. So that's why I really want to make sure that, you know, we let them know we're aware of what's happening. Because again, change is going to happen. We're not going to be here forever. You know, that younger generation will come up and they would probably say, you know, we're going to do this. You know, so those are things that I actually want to make sure that we're clear of also too, and also with our public to make sure they're aware of that. So, but just to have that kind of thank you.
Is it possible to get your group's NPI numbers? That way we can research you guys too. I mean, I've never really, you know, heard of you guys. Are you guys all ex-employees of IHS?
I can answer some of that. I do have an NPI number. NPI numbers are public, and you can
Yeah,
search them on the
that's why I wanted it.
database.
I want to do my own research.
Yeah, so I'm a practicing physician. I do have an NPI number 1024. I mean, it's something, right?
Yeah.
I can give it
And
to you.
that's information that we need, because our people, there's 30,000 of us, and probably 25,000 of us are Kuja. We're sick, you know, we need healing. And we need a little bit more than you guys promising us something, you know?
So I think that it would be helpful. Thank you so much.
Yeah.
I really appreciate.
I mean, these are important questions, you know, these are things that, these are things that we as legislators need to look up on you guys, because practice under your belt. You know, it's bad enough we get reject doctors from IHS that come here just to pass time, you know? Our people get limbs cut off, our people die because of the ugliness that we get treated with disrespect from the higher up. So if we wanna ask you guys your MPI number so you can show us your credentials, then what's wrong with that? You know what I mean? What's wrong with that? This is our life that we're entrusting with you guys. The least you could do is let us look you up.
Yeah, well, you can,
Here's my MPI.
so not all of us are physicians and practitioners, so we don't.
Yeah,
But
so-
my company has an EIN number, you know, for tax purposes.
That's part of it, is your firm is a consulting firm to help the tribe make, the tribe's gonna be the MPI, the tribe's gonna be the provider of care.
Yes.
We're not providing any care, we're just,
I'm
we're
just asking.
yeah, we're consultants that are here to help answer your questions.
Thank
And
you.
make you make the right, and try to help you make the right decision, or the decision you're making, because ultimately, the health charter is gonna be the entity that has the MPI, you're gonna be running your own health.
Okay.
We're here.
Well, I'm just asking because
I understand.
you guys are the new board members. You guys are controlling a lot with the health board. And we have never really gotten anything clear from them. So, you know, I'm just asking because I have every right to as a Sichungu. I can ask any outsider that's coming onto this reservation what the heck you really are doing. And Emily had some very good comments, you know, I back her up on those statements because this is something that is very big. And, you know, we should be sitting probably in a big auditorium. And there should be rows and rows of Lakotas here. And I bet you they'll come from other tribes if we give that opportunity. You know, power's in the people, not here.
And I don't have an NPI number, I'm a physician, but never private practice.
Okay.
But, I mean, Google or background check, whatever you want to do, I'm more than happy to share my information.
And it'd probably be helpful to have a little synopsis of each of the board members and each of our consultants. Because we have a couple consultants that aren't here today that work on various pieces, you know, nursing background, mental health background, business office. So you asked a question about how we're being supported, and so that's something that's in the finance, you know, department. So there's two pots of money that are, you know, strategic around things. There's pre-award activities, and then there's this tribal management grant. And we help the tribe write the tribal management grant, and one's looking at their existing business office functionality. Because those are pieces that need to be reviewed as a part of this process. There's like 5 projects over this 3 years in that, and we're just in year 2. And in year 2, we have identified 2 things. One is doing free accreditation for CARF. So that's your rehabilitation, which would be your mental health services. And that's kind of on hold right now. Another piece of year 2, it was to do the community needs assessment. And it's not been identified, move forward with that yet. So each of those have a budget in that tribal management grant. And then the other is the tribe, I don't know when they allocated the resources, that's what and so when we bill our time specific. Were we working on a grant or were we working on a pre-award? Because the pre-award is what IHS is going to reimburse. So we have that worked out with Skyla and her accounting and the department. So they get invoices all the time from us, and they're identified as a pre-award budget, so they will track that. There's also pre-award for staff that attended our group sessions over time, that everybody did a sign-in, how many hours. I think 2 of you attended one of those in September. We got that sign-in sheet. So that's documented as that was your time learning about or contributing under pre-award about this whole assumption. So my assumption is the finance department is keeping that record of whoever have been team members, how they documented their time. We just provided a tool. That piece will be reimbursed back to the tribe. Their travel and their,
Quick question. Is there a timeline on that as far as like, say this comes up to a vote this summer and the tribal, or our people say we don't want it right now and there's a delay in that? And then say next year or 2 years or something like that, we pick it back up. So the reason I'm asking is, it's reimbursed if we compact our contract, but if we don't, then we're liable or out,
well,
right?
then, to keep the clock going. So you would issue a new letter to the agency saying, there was a letter sent, and this is before we showed up, a letter sent under the previous president, and it had an amount to it. So we're actually at the point where a new letter needs to be written to let the government know, well, the pre-award cost, and we kind of throw a budget in there. You don't have to, but we could see that it could come to this level. For this type of operation or assumption, you could easily be looking at several $1 million of your time, staff time, our consulting, all this legal stuff. And so the legal services are through us, well, not through my firm, but we have a contract with Elliott, with Hopstrauss. And so you're not getting separately billed for the legal services that come. It's a straight pass-through. I don't mix it with my invoice. It's an invoice from my firm, but it's only for legal services, and it's spelled out that way. Because it has to be tracked separate. And, go ahead.
Can I add something? Something that some of you may want to think about is coming up in April 15th, the 18th is the National Tribal Self-Governance Conference. It's run by the organization.
It's Phoenix?
It's in Phoenix?
Yes.
Great conference because then you're around, it's funded by IHS and Indian Affairs, but they don't plan it and they don't operate it. It's operated by tribes. The self-governance tribes are both programs are the ones that organize it.
Last week
And it's a very good conference. You run into a lot of other tribes that are doing the same thing, that have gone through these issues. You can have discussions with them about the pros and cons they went through, successes. And to me, it's a great conference for that reason. Because you get to see your peers that are out there and that are already gone through this issues.
Thank you. We did get that just recently, so I hope some of us will be
And
able
if
to
you go, those costs would eventually could fall under this pre-award. The tribe could give reimbursed for those costs.
Okay.
Yes.
As long as you keep track of them and have it.
So let us know if you're,
Yeah. And if you go to Chris's booth, he would give you a piece of candy, but they said you can't have candy.
I'll find something.
I just wanted to suggest as part of information for people, maybe putting in your guys' names and your
Yes.
background and history. There's a lot of trust issues and a lot of fear, like I said. And also I wanted to know about Mr. Frank Merklin. Why did he step down?
He's a pharmacist, and the tribal council, all of these were approved by the previous tribal council. He's seated on the board, and he has purchased some other pharmacy businesses, and he felt like he needed to spend time on integrating that business, and so he submitted his resignation. So the board is going through the process to identify and seek a new member. Actually, probably 2 members.
I think that it's a good thing to have other Native Americans educated and doctors on the board, and people aren't aware of that. So I think it would be really helpful to get that information down as well.
So we're looking at 2 of them.
Chris, can I ask you a question?
Yes.
I know everybody was bringing this up around the end. Going back to the Snyder Act and treaty rights, let's say that the compact goes forward, the Rosebud Sioux tribe takes responsibility for their own health care. The people come to the representatives or tribal council members and say, we want this, we want this. They go to the health board, we put it in place. The hospital fails in 5 years. What happens if that fails? Is IHS out clear and free, or do they reassume responsibility?
The tribe would say, we're giving it back, and they would have to receive the services back. They're not off the hook at all.
The 638 compact basically makes the tribe responsible for their own health care. IHS funds that, but if that venture fails, they still take over health care and fund at what you currently are expecting, but what you hope is that the tribal council therefore can deliver a better product for you. If it fails, you're back to the product that you've become used to, which you should not have become used to.
Right. And then you will negotiate what are you getting, which pieces might want to give back. But, so,
Yeah, so
there's
the
been
general-
only like 2
Yeah.
assumptions in all the history where the tribe said, we did this too early and we're giving it back. That's it.
So if we decide that it doesn't work and we want to give it back, is there a gap in healthcare?
No.
Are people going to be left without services from
No.
the time that it's being given back?
No, and as Chris
And
said.
what happens to the physicians? There's a be a lot more.
Yeah, so this is incredibly rare, so what Chris has said. So again, there's 2 things. So reassumption, IHS takes it back because of some sort of challenge or mismanagement, and then retrocession, so the tribe gives it back.
But yeah.
So there's those 2 processes. So that can happen. There's been cases where small 6 or 8 contracts have been retroceded or reassumed. It's very, very rare. Of all the hospitals that have been 6 or 8, none of them have gone back to IHS just because there's so many financial advantages to tribal management. So it has not, that's not happened anywhere in the country.
But has it been done with a tribe as large as ours?
Oh, yeah. I mean, with, Navajo Nation, Cherokee Nation, throughout Alaska.
Did you say is there a tribe your size that has retroceded back?
Oh,
None.
None.
Compacted.
Oh, yeah, compact.
We compact, yes.
Yeah.
Like, my tribe is shovel ready to replace the Hastings Hospital, which we've outgrown, and the tribe is spending $400 million for new buildings.
Yeah,
They have not done that if they've not been in self-governance
Yeah.
in the last 20 years.
And to reiterate,
It's remarkable.
yeah, more than 60% of the IHS budget is now managed by tribes. More than 60% through 6 or 8 contracts and contracts.
I guess I just have a comment about, I guess we have to just trust, I guess, that if we fail, then that IHS will take it back. And I don't trust that.
That's written in the law, they have to.
Because, I know, but look at the treaties.
They have to do.
That's
You don't want to go that
really
far, but they have to do
hesitant,
it.
like, it's hesitant in court, and I think that's where the hesitation comes from in the public as well. I mean, you're asking us to trust the federal government that has failed our people time and time again. So, I mean, I know that's not directed at tribal health, right? It's directed at IHS and that failure, but that's just something that gives me cold feet as well, is that we're asking that.
Yeah, and a lot of these discussions came up when the old Sioux was being 6 or 8 as Oyate Health Center. I just visited with them yesterday, and in the several years now that it's been under local management, they're really thriving. I mean, they're at the point where they have cash on hand, instead of operating in the red, and they're also at the point where they're paying for level 2 PRC referrals instead of denying some of the level 1 referrals. I mean, in a relatively short period of time, they're just thriving. So, I mean, once it does move in this direction, at least in my experience, even locally, we see really good outcomes. So, just another thing to keep in mind. Also, another community, Winnebago, of course, they situated their hospital too. So there's another relatively local example of really good success of that process.
There's a lot of good things that can happen with it, but there's also the fear that we have to be that spokesperson to bring those questions and those fears, so you guys can lay those to rest.
And it is developing trust and having public, because until that action occurs,
Because
then
you
there's
guys
the
told
road
us that
back.
there was a letter of intent that was given back in 2021, and there's a lot of us that didn't even know that letter was sent out. So, I mean, there's just, we're not informed. A lot of people are not.
Is there more questions? Emily, you have some more there?
Trying to think of how to ask it, I guess. So like in the examples that you provided for, other success stories, is it normally, common practice, I guess, to start the way we have? 'Cause in my mind, it's a little bit backwards, and I know I said this earlier, but even the creation of the chartered entity seemed like that should come a little bit later after, you know, people are approving of it, after we have a plan, after we have a vision, after we have some staff, after we have some budgets, after we have, you know, something. And I guess the reason why I'm asking is because I read the charter and we're out of compliance. We haven't gotten any public notices for the meetings. We haven't gotten any reporting on it. And I was told it's because they're not functional. So if we're not functional, that's telling me we're not ready for that. And so I'm almost wondering what's going on and why even have this other charter if we're not yet ready for it, because it's very confusing to me. It's confusing to our tribal programs. I have tribal programs coming up to me saying, who's my authority, who do I report to, and now it's both. I mean, there's so many different things, and so I'm just wondering if we're really at that place in this timeline to be taking all of the authority away from our people and our council and trusting. And I don't want this to come out like I don't appreciate. I mean, especially hearing that you're not getting any type of compensation. I mean, I'm so appreciative that there are people out there that believe in this, that believe in our people, that believe that we deserve better, because I believe the same. So I don't want that to come across like I'm not appreciative, because I am. But I'm very concerned because of all our people are not involved, because our people aren't on board, because we don't have X, Y, and Z that we've talked about today. Are we really at that point? And does it even make sense to go forward with that, knowing that we still have so much of this other work to do?
So it's kind of two questions. One is, have other communities done this similar type of process? Maybe in your experience?
Yes, you have two early processes you could develop. Is one, that this is a tribal managed, tribal governed by the council or the executive office. My tribe, it's under the chief, and then we have our health board is just up to I think 13 council members out of 17 can serve on that. They self-attest, but it doesn't give good governance, in my opinion. And other tribes do set up a structure, an independent agency and or commission. This is an entity, so it is the health board. And at this point, the health board and its focus is only around the necessary matters about the future assumption. They're not providing direct oversight over all the other tribal health programs today, because the tribe's not relinquished any of those budgets that we even fall under them. So that's still a one work on the tribe side. So it's
But I guess my question is, like, in my mind, we're still in this planning, visioning stage. Like, it makes a lot of sense to remove the politics, to have this amazing board with all of this expertise of medicine on board to run a hospital, right? Once we get there, but we're not doing that. You guys aren't running the hospital. We're still planning. And so in my mind, you'd want somebody with business in there. You'd want somebody with financing in there. You'd want a different team than what's assembled. And I'm not saying anything against this amazing team, because it is amazing. So again, getting back to, is it needed and is this timing right? Because I don't feel that, or I'm not hearing that it is. And why would we do that when something else may be needed in the interim?
I think we give an example. One thing that Winnebago example from my side, as I said on the federal side, when Winnebago compacted, they spent well over a year, almost a year and a half, doing just what we're doing right now, and developed a tribal health board. They have a health board.
But was the health board developed before any of that year and a half work?
Yes, because that's the leadership part of it.
And did it contain nobody from the tribe?
I don't exactly know who all was on theirs.
Because he said his is his health board.
Pardon me?
The example you gave was your tribal health board. And we already had a tribal health board.
But that health board was essentially trained and established to manage the whole assumption of the compact as they move forward. That was their job. And as part of that job is they started building that leadership team that you just talked about, finance, HR, CEO. They had all those people in place before they compacted. That's startup costs and pre-award costs, but that's all that part of it. You kind of have to have board policy, whether it's a health board or a health organization. They're kind of the overall piece that pulls it all together, but then under that you start building the leadership team. And then as the data comes, you take it over, because you got to start building from the top, you want to go from the bottom up. So that's how they did it, and it took them.
So why is our board out of compliance then?
What's that?
So why is our board out of compliance?
that's the board has to decide on that. I mean, it's new, I think that's part of it, is it's new, they're still trying to figure out all those pieces. So
It's almost a year old, so I'm just.
Yeah, I understand what you're saying. I mean, I think that's gotta be reviewed, that's a board issue, that has to sit down and review that. And part of it is, I think, we've also kind of been put on hold.
Yeah.
When we started doing all these compact meetings, the community meetings last fall. So we really haven't done a lot of any work in the last 3 months, I would say. Just kind of all waiting for some of that, so. But Winnebago, it might be worthwhile having somebody from Winnebago come and talk, because they went through this process for like 2 years. The planning and then I get serious at one point, and that's when we really start all this data gathering and stuff, and then they started moving some things. They started with a board that was going to operate the hospital. They hired a CEO, they had an attorney involved.
Yeah.
Because they were taking over the hospital too.
Thank you.
Thank you. Another question I have is, it says in here for the facility replacement. So if this was to go through, it looks like there's going to be a work to put up a new hospital.
Yeah, through the joint venture process.
Through the joint
that
venture?
they talked about before, yeah.
Okay.
And again, the big advantage of joint venture is that it's a one-time, cost to build a new facility, and IHS staffs it in perpetuity. So
Okay.
it generates a lot more long-term revenue from IHS once
Okay.
it's built and staffed. Yeah.
Okay.
But we have to find the funding to build it.
Yeah.
So the tribe has
So-
to find the funding to build it.
So we're the ones who are responsible for that funding, right?
So we don't get the staff of a new facility until we find the funding to build a new facility ourselves.
You don't get the staffing knowledge until you actually take occupancy.
Yeah, so they won't
Okay.
get funding to build a new facility.
And then that's how we would have to like find our own grants, all of that?
Yeah, and then you pay it back, you can get a 40-year loan from the USDA or something,
Oh.
and then as you generate revenue, you pay it back.
Okay. And it says if that wasn't the case, then the hospital currently right now won't even look at that, IHS.
They're not eligible for the joint venture.
Oh, they're not eligible for
They're
it,
not,
okay.
and I just maintains a list of replacement facilities, and Rosebud's not on that list as of right now.
So you would look at, what we would have to do, council and the people, is that we would have to find the money to have a facility that's bigger bigger than what we have now. And find the loan, find the money, and we'll have that paid off, what'd you say, maybe 40 years? Somewhere around there?
It depends, the charter is written in such a way that debt responsibility is assumed by the organization on the tribe.
Oh, okay,
Yeah.
all right.
So-
Another
Now,
question.
the property is another issue. Where the tribe has property to allow this structure to be built.
Okay, so if this is to happen, like you said, you're gonna do your walkthrough, when did you say that was?
We haven't scheduled.
Oh, not yet?
Probably
Okay.
sometime this spring.
Okay. So when you do the walkthrough, you'll be able to target those areas that, we're gonna open, OB, all of those ones. But we have, like, in our Sichango country, we do have, people here who have medical history. They're doctors, PAs, people who are in the medical field. So how do we, it just would make things a little better if somebody from here who has those credentials was to be on this board. One of our own.
Positions, I think that's an important thing to target, yeah. And it was a council decision in terms of who was on the board
Okay.
initially, but
So that is open, subject to change as well?
Yes.
Okay,
The charter, they get the say.
okay. Oh, you get the say of who fills the board, okay.
The
All right,
board-
but,
Yeah, the board would open it for candidates and review it
Okay.
with the knowledge of what I'm hearing.
Okay.
Transact as if the board
Yeah.
is very conscious of having more Rosebud members who have expertise.
And that's just the given, you know, with us as tribes, you know, how we have our own, we want our own. If we can't, we'll just as well, you know, borrow somebody from next door to sit there like you're sitting there. You know, and it all boils down to is the trust, you know, of, well, because we got to answer those questions, all of us. And, you know, I hear, don't sell us out, don't do something stupid where, you know, when you guys are done, that's going to be on you. You know how we play, you know. But, you know, it's just looking at, you know, is this real? I'm just sitting here thinking that myself. And so I'm thinking, well, the people, you know, with what I know and what I'm seeing here, the numbers and everything, and that's good, but it's like mind-boggling because we don't have that. We've never been on a venture of this sort. And I really, there's ways to do this, and it's the people, and you identify those people. Like I said, we have our traditional people. They're the ones who will need to be involved as well in making this happen, you know, if, you know, because the people will ask them. They don't always come here, you know, we're IRA. Here, when we're sitting here, we're IRA, but we also have our traditional government out there. So, you know, just looking at that, I'm like thinking of these other things where we do have a really large population here, and we do want it better. So, you know, it's a lot, a whole lot. And we also have our treaty. Our Fremont, he sits on the treaty council.
Yeah.
So, you know, we get them involved as well.
Yeah, and actually in our, when we did some of the focus groups, it was Treaty Council was one of the groups we talked to, and Phil and Eagle and the whole team, and very much in support of self-governance and recognize that it's still perfectly in compliance with our treaty. So we have talked to them, but that's a good point.
Yeah.
Maybe even some more formal role in the board too.
Yeah, and that's really what the people need to hear.
Yeah.
With the treaty.
Because even in the documents, which would be the compact or contract, the treaty is spelled out that the government, even though the tribe is assuming the relationships, it is not vacating the government's responsibility of that treaty.
We need the floor for Ron. Go ahead.
Thank you, Chairman, Council. You know, we discussed to enemy and watching them talk here. Maybe that when they're doing this with that other house, like Winnebago, we should, council should send these two down to here for their own eyes and experience and bring back information to the council. I think that's my idea of people like there. That these two ladies, go down to Winnebago and check it out and give a good report back.
Yeah.
Whatever.
Yeah, that's a great idea because they're the most recent example in the Great Plains area of a really successful sixth-grade. It was a hospital, and they did a process that's really similar to what is happening here. So I think that's a good idea. But then also, if you're interested in learning more about joint venture, Santee, Nebraska did a joint venture, and so did Flandreau. So smaller, but still did that process. So you could learn from them if that's something you wanted to do. Yeah, so the tribe built the new facilities, in some cases 3 times as big as the old one, and then IHS is responsible to staff it in perpetuity. Isn't it? I mean, it's amazing. So I mean, just hearing it from them, I think would be really powerful because they're actually, you know, living through the long-term outcomes now. So again, Flandreau and Santee for joint venture, and Winnebago for the 6 or 8 of the hospital.
Can I interject here? You said the government has to fund it for what was
In perpetuity, meaning forever.
Now, what do we do about these condos that we get up there?
The what now?
The Congress people we get.
Yeah, so
Congress can do just about anything they want to do. Not just any of us out here.
No, that,
you, me, cowboy, anybody.
that is absolutely 100%
Can
true.
do anything.
Yeah.
They can defund this, they can defund that. They can put 5 hours in.
No, and that's absolutely true. What you're saying is that Congress could do this, and IHS is a discretionary program. But IHS could decide to defund IHS. I mean, Congress could decide to defund IHS whether or not you're 6 or 8. You know what I mean?
Right.
So yeah, but it is written into the law for authorizing the joint venture is that they are responsible for funding the staff.
They can change that.
Yeah, they could. Joint venture's been around since the 90s, is that right?
Yeah.
And so we've got 30 years of experience where that hasn't happened. But you're right, I mean, Congress could just defund all Indian programs. Horrible, it would be, but you're right. Congress could happen.
Okay, any more questions for our guests here today?
I just have one.
Yes.
So, let's say we don't move forward, right? Is there any way that we could, change IHS's policy, fix the care that our people get? We don't really have that voice, right?
No.
Unless we do this.
And it's an excellent question, but IHS is a federal program. You know, so the policymakers are largely in, for us, it's Aberdeen and Rockville, right? If you want the health policymakers to be here, 638 is the process to do that, you know? So I mean, we've been asking for improvements in IHS for decades. I've been involved in National Indian Health Board and Tribal Technical Advisory Group for decades, and look where it's gotten us as far as IHS. And the one outcome, again, is that the vast majority of IHS is now 638 because the tribes are recognizing, waiting for IHS to improve it, is it hasn't happened yet, you know, but where we do see significant improvements in healthcare in Indian countries, the tribes that manage it themselves.
If I could interject one more time. We won a pretty substantial lawsuit here about that.
Yes.
And after we won it, the question was, what did we win? So, in further discussions, and I talked to the chairman about it, he's had discussions with the senators through the rounds, and they want the tribe to bring them something, some document of some sort, where they could use that lawsuit to do exactly what Jordan was talking about.
Yeah, and actually,
That needs to be done as well.
And we've been tasked with working on some of that.
And just as a,
Accurate documents and there's been discussions with Buildings and Grounds offices.
and during that lawsuit, during the council at that time asked me to provide an expert testimony for that lawsuit, which I did. And again, at no charge, you know, because I love my people, so I just do it. But we did provide an expert testimony document for that lawsuit that the tribe did win. But we can use that lawsuit as part of the leverage for the joint venture, for example. And I don't know, Dan, if you wanted to talk about some of your discussions.
Yeah, that's, President Herman asked me to come along with him to meet with Senator Sioux, and that's where what you're talking about really came about. They're in support of that because of the lawsuit, and so what they want to plan on from us on what we can offer to them. Right, exactly. And so they're behind us because we're South Florida, so.
And just to talk about, we've talked about joint venture, but it's a very high level thing, talking about replacement of the facility. And the joint venture is an avenue, working with your legislative folks and using the pressure of your lawsuit, the outcome of your lawsuit. That's really, it has not a good shining star for the agency, but will that have momentum congressionally? And that would be funding for both construction and the staffing package. And then there's another vehicle where you just, you do your planning, use the software systems that Russ has access to, and you just go out on your own and say, we're tired, we're gonna build this new facility, and under that, your debt would be retired with what is called the 105L lease. The joint venture doesn't qualify for that because you're getting the staffing package. But if you're not having to obligate your third-party money in that, you've got another vehicle that retires the debt, then you create your stacking package with all your third party. So there's like three trains going down the track, and it's which one is gonna work. And so we kind of think in terms of that on our team, which way could it go? Emily?
Thank you. Sorry, I just had nothing new, just to follow up on that when I was looking at my notes. And for the funding question that I have on there, it says that I asked, how long and how we kind of spent. I have here that we're on year 2 of a 3-year grant, but I didn't ever hear an amount. Do we know how much has been expended, at all of it as far as the meetings and, everything in general, not just what you did, but just in general, to get us to this point?
I don't know on the tribal side, on the tribal management grant, it was tiered, so much in year 1 or 2.
Emily, but I did make a motion for that under the treasurer's report, so that will Skylar's gonna get all that information.
Oh, so we just don't have that yet?
We just don't have it.
Okay.
It's what it's called the pre-cost award amount.
Okay.
And so she's gonna include everything that.
Will that include like a summary, what
Oh,
work
yeah,
was?
and it's gonna be what all the community education costs and everything in it, so.
So it'll include all the meetings and travel and all of that?
Well, Skylar will be providing that to our treasurer, who will give a report to us. There is a council motion on it last week.
Thank you.
That's right. And having that will, I'm sure we'll be needing to write the agency a letter to up the amount, because I think it was like originally $500 and some thousand in the pre-award.
And have we expended that?
No.
No, but yeah, I don't know what you've done on the tribal side. It's not been expended toward us. And anything we bill under the tribal management grant is not eligible for pre-award. So that's a whole other bucket. So we have been creative on how we work on some activities here to get to this point.
Thank you.
But we want to stay ahead of that and work with the leadership. Elliot can write the letter and then move forward with the letter.
Is there any more questions, comments?
I'm good.
I know we'll think of some on your way home tonight. We didn't ask. We built it.
Just want to say, Wopila, that it means a lot to me just to be trusted enough and be invited to your beautiful community meetings. It truly does mean a lot to me.
We have our short list of duties here. Thank you so much.
Yes, if I could please. I know it's too late.
I sterilized my hands, so we're good. Okay, love.
Thank you so much.
Thank you again. See you again. Yes.
Thank you again.
Thank you so much. Yes. Thank you so much. Thanks for coming.
Yes.
Appreciate it.
Thank you so much.
Thank you.
I was at
We appreciate your answers.
I didn't get it,
Thank you
but
so much.
on your question about repayment on joint venture, ours, we paid back in 5 years. It was a $25 million note for about, I think it was 30 years. So we went to the max, we paid it off in 5. So we're free and clear of all that third party. And we didn't even use all of our third party to pay it every year. It was just we carved out that.
Thank you very much. Glad you came. Glad to have you.
When we're done, we want to
Lisa, you want to take 5? Or you got something that's going to be quick, right? Okay, let's do that.
No.
Otherwise, I need a break.
She wants to go into exec.
We do?
She does.
You're going to go into exec? Okay. Lisa, you're moving to go in? Sure. Second?
I just wonder what we're going to, just so that people know.
Is a second? Executive session?
Better tell Brookie if you are.
Give me a second.
By Jordan. Question by Michelle. Okay, we'll turn off all the buttons.
You better put your phones up. Yes.